And good morning, everyone. Welcome. Let me be the first welcome everyone to the Market Oversight and Transparency Committee meeting. We have actually back-to-back meetings today. So for the first hour from 9:30 to 10:30, we're going to have a regular MOAT committee meeting. From 10:30 to 11:30, it's going to be a joint meeting of the MOAT committee and the Care Delivery Transformation Committee, where we're going to hear about and talk about reducing unnecessary administrative complexity, and then we'll transition to the Care Delivery Transformation Committee. Before we start, I have to say that I'm not sure I needed any more proof that I'm truly nerdy, but like the agenda for today is like enough to convince me that deep down there's like just a core of nerdiness which I just cannot avoid. So I'm looking forward to today. Before we move into the agenda, we do have to approve prior minutes. Oh, before we move into the substantive agenda, we do have to approve the prior minutes. And last time at the beginning of our meeting, we did not have enough we did not have a quorum. So we have two sets of minutes to approve this meeting. The first was for the meeting on let me make sure if I can get the date correct. Oh, thank you. The first is on October 12th. And Colleen, do we vote on these separately or should we?
Well, yes, if we could take a separate vote in case there are any objections.
Okay, totally fine. So the first is for the October 12th meeting. So I suppose I'm supposed to ask, does anyone move to approve the minutes?
So moved.
And a second for them?
Second.
And then does anyone have any comments they want to make, or additions or subtractions? Okay, if not, then I think we should go ahead and vote on the minutes here.
Great. We'll start with you, Chair Cutler.
Approve.
Commissioner Haupt,
Abstain.
Commissioner Mastrogiovanni,
Approve.
and Commissioner Kwasnick.
Abstain.
Okay, thanks very much.
And my sense, I shouldn't speak for people, but my sense is the abstentions is they weren't physically present. So therefore, people are wisely, correctly abstaining. And then the second is for our last meeting on February 15th, excuse me. And so let me ask again if someone wants to move to approve the minutes.
So moved.
And second?
Second.
Okay. And then does anyone want to offer any revisions or changes to the minutes? Colleen, let me turn it over to you again.
All right, Mr. Chairman, how do you vote?
Approve.
Commissioner Haupt,
Abstain.
Commissioner Mastrogiovanni,
Approve.
and Commissioner Kwasnick.
Abstain.
Thank you very much.
And putting words in people's mouths again, the abstentions, I believe, were people who were unable physically to be present at the meeting.
That's correct. Correct.
So we have having gone through the minutes and giving you a little bit of a preview. We have a couple of things to talk about in the first hour. Before we do that, I should probably first say good morning to David Seltz and see if he wants to say anything up front. And I should ask our chair, Chair DeVoe, also, I suppose, if she wants to jump in at the beginning as well, before I just, in my nerdiness, keep diving on in. But David, maybe I should turn it over to you first.
Thank you, Commissioner Cutler, and good morning, everyone. Good morning, commissioners. Great to see all of you here today. Chair DeVoe, members of the public. Commissioner Cutler, as you said, we have a full 3 hours of content. We are going to be diving deep on provider pricing, on administrative complexity, on the Office of Patient Protection, and our investment program. So we set up these committees at the very beginning when we set up the HPC. We actually had 4 policy committees at the beginning. And we set these committees up really as an opportunity to do what we're going to be doing today, which is to kind of dive deep onto a specific research topic, get your input, commissioners, to be able to invite a guest speaker, which we're going to be having in the second hour, and also to just provide additional transparency to the public about the work of the agency. So I am also looking forward, my nerd core is looking forward to the next conversation, but I will turn it over to Chair DeVoe if you want to say good morning.
Thanks so much. Good morning to everyone. And I share your enthusiasm, both Chair Cutler and Executive Director Seltz, for our agenda. Look forward to moving ahead. Thank you.
This is surely the nerdiest group of people I've ever been affiliated with, and I say that with a great deal of pride. Let me then turn it over. So our first issue here is cost sharing for contraception and levels and trends over the past few years. So let me turn it over. I think either David Seltz, I'm going to turn it over to you for this.
Yeah, I'll just introduce this topic really quickly. Just as a reminder, Data Points is a series of research papers that we publish online. They're an interactive series. So each Data Points looks at a specific topic and uses our novel data and research methods to answer a question. And if you go online, all of the graphics are in Tableau and you can interact with the data and look at it in different ways. So for this Data Points, we picked something that is certainly top of mind in a national conversation, but it was also something that we have looked into previously and wanted to revisit. So I will turn it over to the lead researcher on this project, which is Sasha Albert. Good morning, Sasha.
Good morning, Director Seltz. Thank you so much. And good morning, commissioners. I'm pleased to share findings from our latest Data Points publication, as we've been introduced, on cost sharing for contraception in Massachusetts. So we can move to the next slide. So to start with some background, since 2012, the Affordable Care Act preventive care mandate has required commercial insurers to cover without cost sharing at least one form of contraception in each FDA-approved category, as well as related services. And the mandate applies to all plans offered by employers or on state marketplaces. Plans are also required to provide an exceptions process so patients can access contraception that their plans may not cover when it's medically necessary for them to do so. There's been a fair amount of research on the contraceptive mandate in the decades since its implementation, finding that it's had many benefits for patients, including markedly lower cost-sharing payments, increased adherence to contraception, increased access to the most effective methods, such as intrauterine devices or IUDs that often have high upfront costs, a decrease in the rate of unintended pregnancies, and narrowing disparities by income and unintended pregnancy rates. Likewise, the HPC published a study in 2017 finding similar reductions in the burden of cost sharing for Massachusetts residents using prescription oral contraception, which the statistic is cited on this slide, as well as IUDs from 2011 to 2014. Next slide, please. Even though the benefits of the contraceptive mandate are well documented, both nationally and here in Massachusetts, there's been persistent confusion about how the mandate is applied and persistent gaps in its implementation nationally. HRSA has continually updated its guidance on the mandate, recently clarifying that it covers contraceptive counseling, initiation of contraceptive use, discontinuation of contraceptive use, as well as follow-up care. Given that this is a time of significant policy change on reproductive health services at the federal level, and given that the Commonwealth has prioritized access to and affordability of reproductive health care, we thought it was important to provide updated information about cost sharing for contraception in Massachusetts, to understand the degree to which it might still be happening and whether there are any further improvements we might be able to make. And in this study, we look at oral contraceptive prescriptions, as well as other contraceptive methods and services that would involve a visit with a clinician. And for those, we looked at implant services, including insertion, removal, and the implant device, IUD services, including insertion, removal, and the device, IUD follow-up care, and contraceptive options counseling. And we start with our findings on oral contraceptive prescriptions. Next slide. Thank you. So to start with, we found that each year from 2017 to 2020, under 2% of oral contraceptive prescriptions have had cost sharing. To put this another way, patients consistently are not paying cost sharing for over 98% of oral contraceptive prescriptions. In our prior work on this topic, we found that as of 2011, so before the implementation of the contraceptive mandate, 98% of oral contraceptive prescriptions did have cost sharing. So a decade later, we've seen some really substantial change. So keeping that in mind, this slide shows average copay, coinsurance, and deductible payment amounts for a 1-month supply of birth control pills among that small subset, that 2% of prescriptions that did have cost sharing. And as shown here, patients paid about $40 to $50 on average for a 1-month supply, mainly due to spending on copays, as shown in that largest blue piece of each of the bars in the graph. We also found that from 2018 to 2020, the vast majority, over 80% of the birth control pill prescriptions that did have cost sharing were prescriptions for branded drugs. And this is important because the cost sharing on those drugs may actually be appropriate under the ACA. It's fairly common for plans to impose cost sharing on branded drugs that have a generic equivalent when they cover the generic equivalent without cost sharing. We also investigated another aspect of oral contraceptive coverage and utilization in Massachusetts, which is uptake of 12-month supplies of oral contraception following the passage of the 2017 Access Law. On the next slide. The Access Law permitted the prescription of up to 12 months of contraception at a time without cost sharing in an effort to improve access and adherence. And I want to note here that the Access Law applies not only to oral contraception, but also contraceptive patches, intravaginal methods, and injectable methods. Here we investigated specifically oral contraceptive prescriptions from 2017 to 2020, looking at prescriptions for less than a 1-month supply, a supply of at least 1 but less than 2 months, at least 2 but less than 3 months, at least 3 but less than 4 months, and 4 or more months supply of birth control pills at a time. And as you can see in the graph, the share of oral contraceptive prescriptions for 3 to 4 month supplies in the yellow has steadily increased, representing nearly 3/4 of oral contraceptive prescriptions as of 2020. But the share of the bar for 4 or more months supply is barely visible. Consistently, prescriptions in that amount represent under 1% of all prescriptions each year, indicating that as of 2020, at least, there was little uptake of 12-month supplies of oral contraception. And I want to note that there's been some literature indicating that there was a general lack of awareness of the Access Law in the years right after it passed among providers, pharmacists, and patients alike. And we know the Commonwealth has done a fair amount of public awareness work about it last year. So we're looking forward to seeing more recent data on these trends when it's available. Moving now to other contraceptive services received in visits with healthcare providers. We looked at implant services, IUD follow-up care, and contraceptive options counseling, which we examine in what we called encounters, that is, individual visits with healthcare providers that may involve more than one of these services. For example, a patient may be counseled on their options for contraception and then get an IUD placed at the same visit. As shown here, the share of individuals with any out-of-pocket costs for contraceptive service encounters has steadily decreased, from 16% in 2017 to 12% in 2020. But since this slide looks at several services grouped together, we also investigated trends in cost sharing broken down by service to see whether any services were particularly likely to have cost sharing. So on the next slide, we see the share of encounters for each service that had cost sharing each year. While there was cost sharing consistently on under 10% of visits that included implant services in the blue, IUD services in the gray, and counseling in the orange, and while the share of visits for all services with cost sharing has gradually decreased, still about 1/3 of IUD follow-up visits had cost sharing as of 2020, as shown in the yellow. IUD follow-up care takes place at a subsequent appointment after a patient gets an IUD. Those appointments may involve checking to make sure the IUD is placed correctly, or may address any discomfort a patient is having. And so they're necessarily separate visits from the visit during which a patient gets an IUD placed. So we find that patients were much more likely to pay out-of-pocket costs for IUD follow-up care than for these other services received in visits with healthcare providers. And just to give this a little more perspective, our prior work found that as of 2011, so again, before the contraceptive mandate, almost 52% of patients getting IUD services had cost sharing. And now patients pay cost sharing for only 5% of visits for those services. But for IUD follow-up care, patients are still paying cost sharing for about 1/3 of those visits. And in fact, when we look at all encounters grouped together, follow-up care was involved in 60% of all encounters that had any cost sharing. Next slide, please. Even though the share of individuals paying cost sharing for contraceptive encounters has decreased over time, those who do still face out-of-pocket costs are actually paying more over time. This slide shows average per person cost sharing amounts for contraceptive service encounters among those with any cost sharing for those services. And we found that average total cost sharing amounts rose from $60 in 2017 to $103 in 2020, more or less entirely due to rising payments on deductibles, which you can see in that gray portion of each bar getting larger every year, even as copay and coinsurance amounts were basically unchanged over time. However, I do want to note that although IUD follow-up care was the most common source of cost sharing, as we discussed on the previous slide, it's actually not the most expensive for patients. Average out-of-pocket costs specifically for follow-up care rose from $42 in 2017 to $61 in 2020. By contrast, for IUD services, so visits where patients get an IUD either inserted or removed, average out-of-pocket costs rose from $90 in 2017 to $157 in 2020. So even though it's much less common for patients to pay out-of-pocket for IUD services than for IUD follow-up care, IUD service out-of-pocket costs are much more expensive for that small subset of patients who still have them. So to wrap up on the next slide, we found that while there have been some really substantial improvements in the prevalence of cost sharing for contraception since the last time we studied these trends, opportunities for further improvement remain. We find that while a steadily decreasing share of Massachusetts residents are paying out-of-pocket costs for contraception, those who do still pay out-of-pocket costs are paying more over time. And that while cost sharing for oral contraception, implant and IUD services, and options counseling has become relatively rare, cost sharing is still fairly common for IUD follow-up care, where about 1/3 of visits still had cost sharing as of 2020. On the previous slide, I showed our finding that rising cost sharing amounts for contraceptive encounters come from rising deductible payments. And about this, I want to note that that trend may be a reflection of affordability trends that the HPC has discussed in other areas. Specifically, rising enrollment in high deductible health plans due to the increasing unaffordability of health insurance premiums, which can lead individuals to seek out plans that balance lower premiums with higher cost sharing responsibilities, and likewise can lead employers to offer less generous coverage to try to control the cost of providing it. So downstream of those trends, individuals' payments towards their deductibles are rising over time. And it's particularly striking that we see that trend in this particular study, because we're examining a set of services where patients largely shouldn't be paying out-of-pocket costs at all. Also, earlier in the presentation, I said that the small share of oral contraceptive prescriptions that still have cost sharing may be appropriate under the ACA because they're mostly branded drugs with generic equivalents. But I do want to note that even when it's appropriate under the ACA, persistent cost sharing may still represent an access barrier for patients when patients expect to receive contraceptive services and medications free of charge. And this is especially true for individuals with lower incomes, who are less likely to be able to absorb unexpected costs. Accessible, affordable contraception is especially important in the current uncertain policy environment around reproductive health. So we recommend that providers and payers ensure that they're following the latest guidance under state and federal mandates, and ensure that their patients have up-to-date information about their rights and options, so that contraceptive services and medications are covered as intended. Thank you very much.
Sasha, that was really interesting. Thank you. Can I start off just by asking two questions, just factual questions, and I'm not, you may or may not know the answer. The first one is, if I recall that there's the birth control pills may move over the counter. If that's true, and insurance therefore would likely not cover them. And so for many people, that would be an increase in cost, even though presumably the list price would go down, that often does, but the out-of-pocket payment to the individual might go up. So first question is that correct?
Yeah, my understanding is that, I mean, it's hard to say how the prospective over-the-counter birth control pills will be priced. But yes, it is possible that patients will be paying for medication that previously they would have gotten free of charge. But I think the the issue of over-the-counter birth control pills really gets at sort of what the access barrier is for patients. If cost is the main access barrier, then moving pills over the counter doesn't really address that challenge. But if access to the medical system is the barrier, then over-the-counter birth control may help.
It'll be an interesting test of that, I suppose. The second question is just, do you happen to know what share of pregnancies in Massachusetts are unintended?
That is a good question. I know that nationally it's close to half. In Massachusetts, I would need to investigate.
Okay. I wonder if that's gone down over time as people have had greater access to less expensive birth control methods. Patty, let me turn over to you.
Yeah, I just had a question about, you were saying that the IUD follow-up procedures were often subject to a deductible or a higher co-payment. Do you think that's a coding issue?
It's a good question. The 2021 guidance from HRSA on the mandate specifically clarified that follow-up care needs to be included under the mandate. And unfortunately, our data for the study only goes through 2020, so we weren't able to measure, any changes that may have happened after the updated guidance.
Yeah.
But the fact that was clarified a couple of years ago indicates to me that there may have been a lack of clarity about how to address those services before. So, I'm not sure whether I can say that it's a coding issue or, providers' awareness that the subsequent appointment should be grouped with the first, or, payers flagging to payers that they need to keep an eye out for it. It's hard to say exactly sort of what the source of confusion was, but I given the updated guidance, it seems like there was some confusion about what to do with those services.
My other question was, you were talking about the increased cost for birth control pills for brand name. I know in other areas of healthcare, sometimes women have allergic reactions or some type of reaction to generics that don't work in exactly the same way because of fillers or binders or whatever is put with the medication. So I would believe that you could get an exception from your carrier, as you can with others, for full coverage if you had a problem with a generic substitute.
Yes, that's right. Plans are required to have an exceptions process, so that patients can access forms of contraception that are not on their plan formularies.
Yeah, so I just don't know if people know that they have that option available to them and are therefore paying out of pocket when it should be covered in full.
Yeah, I think that's right. I mean, I think the existence of the exception process is essential, but I think it's also difficult to rely entirely on patient self-advocacy to resolve these gaps.
Yeah. Thank you.
Thank you. Does anyone else want to jump in? Oh, Martha, yeah, go ahead.
Yeah, I just wanted to, based on Patty's comment, I just wanted to flag for people that DOI did put out an FAQ on the access law, which does cover some of the questions like, how do I get an exception and things like that. So just wanted to share that in this space to make sure people were aware of some additional resources.
Thank you.
Thank you. And I believe they also have, or at least there's a page on mass.gov. I'm not sure if it's a DOI page or someone else put it together, but it includes information specifically for patients, for providers, for pharmacists. And so there's a fair amount of information available about how to engage with benefits under that law. Yeah.
My past life, I helped a DOI with that and engage with stakeholders on it, so that I know that's a pretty thoroughly vetted document, which is why I wanted to make sure people were aware of it.
Perfect. Thank you, Sasha. Thanks very much.
Thank you.
Okay. David Seltz, maybe I should turn this back over to you to tee up our next discussion on the pricing issue.
Great, sounds good. And thank you, Martha, for flagging that document. And we'll make sure to provide a link to that information next to our data points when we post it online. So for our next agenda item, which will take us through to the end of this MOAT meeting, we wanted to provide a preview of some of our findings from the upcoming 2023 Healthcare Cost Trends Report. And on the next slide, this particular work is focused on excessive pricing in our healthcare system. And we really wanted to focus on this particular topic because it is so well aligned with the agenda for action that this board discussed at our first board meeting in January. At that meeting, we talked about some of the priority areas for the HPC to pursue this year. And this topic, while probably most closely linked to our work to bolster our cost containment activities, also is aligned with our work around health equity and enhancing pharmaceutical transparency and accountability, as you will hear. But the relation to the bolstering the HPC's cost containment activities, as you'll see on the next slide, is really reflective of last year's policy recommendations in our cost trends report, where we made a kind of priority recommendation to the legislature to take action to strengthen our cost containment strategy by pursuing 3 different goals. One was to strengthen the healthcare cost growth benchmark. The second was to address excessive provider and pharmaceutical pricing. And the third was to make health plans more accountable for affordability. And in the recommendations, we really felt that these 3 different mechanisms fit together, that this was a comprehensive approach. And so to really advance our thinking and our work on this second one, which around excessive provider pricing, our research team really wanted to do a deep dive this year into understanding the variation in commercial pricing and how that compares to other reasonable benchmarks. I would just note at the top, as we do in past years, we tend to preview our findings from the cost trends report over a series of meetings with you commissioners and with the public as an opportunity for you to provide input to us as we develop the full written report. That full written report will likely be brought before the board in September. So we have a lot of time, and as you'll hear in upcoming meetings, we're going to be rolling out these findings over the course of the next few months. So with that, just as an introduction, I'm going to turn it over to David Auerbach to lead us through this presentation.
Okay, thank you, David. All right, and this will be fairly long, but I'll do my best. There's a lot of material here, and it's going to take a while to set up and talk about what do we think really are excessive prices? How do we define that? And so we'll spend a while talking about that and then show some results. And as David said, this is preliminary, this is open to feedback, and we'd love your thoughts. So let's go to the next slide. Okay, so to kind of frame and set this up, reducing excessive healthcare spending is essential to achieve an affordable, equitable, and accessible healthcare system for all residents. We know as a backdrop that commercial healthcare spending has been growing pretty rapidly over the last couple of years, about 5% averaged over the last 2 years. And at the same time, income has only grown about 2% over the last 2 years. So it's faster than income. Combined family health insurance premiums and out-of-pocket spending are about $25,000 per year today, on average in Massachusetts. And these trends are unsustainable for our government, for employers, for small businesses, and all residents. There was even an article in the Globe on the weekend about the shrinking small group market, and somebody noted they were facing premiums of $40,000 a year, which was it's just so much. It's so much. And premiums that continue to outpace income growth will decrease take-home pay, lead people to continue to avoid care. They will make healthcare outcomes worse and force people to choose between healthcare and other basic needs. So if we do want to limit growth in healthcare spending, we're going to have to find areas where spending could be, where growth could be moderated, where spending could be reduced. And that's hard. At the same time, we know we want to increase spending in some other areas. We want to increase spending, invest in primary care, behavioral health care, health equity, and reducing disparities in the workforce, and a lot of other areas. So in this healthcare cost trends report, we are going to return to a theme from 10 years ago where we talked about some of the broad literature of where is healthcare spending wasteful. And we're going to try to be more specific and concrete about areas where we think that spending is excessive and where savings are achievable within the current system. So more than a theoretical exercise, but a fairly concrete accounting, if we can, about where there is excess spending that could be reduced without harming quality and access to care. Okay, so next slide, please. And so today is sort of maybe the largest chunk of that effort, as you see. The cost trends report outline will be our first chapter, like usual, running over some of the drivers and trends in spending. Our novel chapter 2 this year will be about excessive spending, as I just mentioned. And this will be divided into a few subsections: excessive prices, excessive utilization, and excessive administrative costs. And so today I'm just talking about the price part. And we will also have our chart packs, as usual, with a new edition of a primary care and behavioral health chart pack this year. And we'll present some highlights of that at the June meeting. And then our dashboard and policy recommendations should come to you in July. Okay, next slide. And I also just want to say this discussion about prices today is part of a series of publications that are all somewhat related. So to understand today, the question we're asking is, what is the extent of excessive commercial prices in the Massachusetts healthcare system that could be reduced without harming quality? But we're not talking as much about policy actions you could take to get at some of that. That's going to come more later. In the fall, we'll be talking about what are some of those policy approaches. If we think that there are excessive prices, what could you do about it? And we'll talk about ways you might approach that. We will also be led by the market oversight team in the fall, revisiting a focus on provider price variation, updating some of that work that we did in 2015 and asking of that variation in prices that we see, what's underlying that? Is it related to quality or public payer mix or market leverage and things like that? So these three are publications to come, all on the topic of prices. Okay, next slide, please. So to start this discussion, I just want to give a little background on where prices come from in the commercial healthcare market. And I'm being pretty broad and not very nuanced, so taking some liberties, but to try to simplify this very complicated topic. You can think of in a competitive market for laptops or something like that, where do the prices come from? Well, they're naturally limited by what people are willing to pay. I'm perfectly comfortable deciding whether I think this more expensive laptop is worth $500 more, and I make that decision. And if those prices get too high, nobody will buy them anymore. And that is going to limit the prices of that. In healthcare, it doesn't really work that way. We don't want individuals to be deciding at the time of care, is $2,000 too much for this MRI? Is $50,000 too much for this surgery that my doctor tells me I need? So we have to set prices in a different way that doesn't have the consumer in the middle. So what most countries and what we do in Medicare and Medicaid, and what we do is we have the government or a large third-party entity sitting down and deciding, with the providers, what are fair, reasonable prices that meet the goals of efficient provision of care we might have, and just the kind of goals we have as a society. And we don't do that in the commercial market here in general. Prices are just determined by individual providers sitting down with individual insurer, and what we get are the outcomes of those negotiations. And then on the next slide, so that might get us some results that we don't like in all cases. It depends on the relative leverage of that provider and that insurer. And so you don't always get prices that reflect efficient provision of care, that reflect quality or value of care to society. In some cases, the provider might have more leverage. This is often the case with large provider systems or providers of specialty services without a lot of competition. And those prices tend to be high. The insurer can't really say, I'm going to exclude you from my network. Everybody needs you. And then you have other cases where the insurer might have more leverage over the provider. This is often the case with independent primary care, behavioral health providers with a high public payer mix. The insurer can often exclude those, and those prices tend to be lower. And so we're going to get prices that reflect these negotiation situations. And that's a lot of what we see. And prices, of course, even vary, across the same sort of hospitals, for example. So on the next slide, so, to give an example of, so what I was saying earlier, those prices tend to be high when the providers have more leverage. What do we mean by high? How do we even evaluate that? Well, one way is to compare to other countries. And here's just a couple of examples compiled by the Healthcare Cost Institute, comparing the US to a number of countries on hospital admissions for angioplasty. We see our prices, 32,000, several times higher than everywhere else. Or for an MRI scan, the same situation, 1,400 compared to several hundred in these other countries. Okay, next slide, please. And so here are some of the results of that mechanism for determining prices in the commercial market. We tend to get unsustainable and unaffordable healthcare premiums, high out-of-pocket costs. And even though some people might argue, well, if the prices are too high for some things and too low for other things, we'll cross-subsidize and it'll all work out. But what you then get is you get everybody wanting to expand the high-priced profitable stuff. We get too much of that. You see lots of imaging centers and cancer treatment and orthopedic centers popping up because that's where the profits are. And we don't get enough primary care and behavioral health care. Those are money losers. And so we get a system that is going to be tilted towards where those higher prices and profits are. And then care gets shifted in that same direction. You'll also get consolidation of services into large systems that are often hospital-based. That's where the leverage is higher. When I expand my tent, I can expand that leverage and those high prices to other services in the healthcare system. And then that leads to more use. And we also get impacts on health equity that we don't like. Providers that are serving public payer patients who are getting those lower commercial prices, they end up resource constrained and have less ability to provide high quality care to those patients. Okay, next slide. So, all right, how are we going to decide then what is a too high price? What is an excessive price? And so we're going to be relying on Medicare to a large extent throughout this. Medicare prices are built up from the bottom where there's a process where they will estimate what should the cost be to provide this service. And they'll look at the time and the providers involved and the capital and operating expenses involved for an efficient provider. And that's the key. And these are built up and they have been changed over a long period of time and tweaked and adjusted, and they have somewhat different adjustments for inpatient or for outpatient services. They'll reflect different geographies, different input costs, and these payment rates grow each year, reflecting inflation in those input costs. And again, they've been developed through a lot of thought over a long period of time. And in fact, most commercial payers do use the Medicare prices as kind of a starting point, and then they might, multiply that by 1.3 or 2.5 or something like that. And in fact, as a comparison for commercial payment rates or commercial prices, remember, we're comparing to prices that are adequate for an elderly population. In some cases, you would actually think those prices should be higher if those elderly patients require more resources to care for than a 25-year-old. So Medicare is kind of our point of comparison through most of this analysis. Okay, next slide. And here to just, address a thought about that we often hear, oh, the Medicare payment rates, they're too low, they're below our cost, we lose money on Medicare. And that's an important point, but if you look at the research over the last 10, 20 years, and MedPAC has synthesized that research, and what they actually tend to find is that that's not Medicare's fault. That doesn't mean those prices are too low. And what they find is that, in fact, providers that are under pressure to constrain costs have slowed their growth in costs more than those who don't face that pressure. In other words, when providers, particularly nonprofit providers, receive high payment rates from insurers, they face less pressure to keep their costs low. And so what they find is that it's not that the Medicare prices are too low, it's that your costs are too high. And that they find that low margins on Medicare result from a high cost structure that developed in reaction to the high private payer rates. In other words, they're saying the high prices lead to the high costs, not the high costs lead to the high prices. And so I'll show an example of this from Rhode Island on the next slide, which is illustrative. So to orient you to this, in Rhode Island, in around 2010, they passed a package of reforms implemented through the Office of the Health Insurance Commissioner. And one really important thing that they did is they constrained the growth in hospital prices. And they did this starting around 2010. And so I'll show you what happened as that played out. First, look at the hospital revenue line, the dark blue. And if you go back to 2011, hospital revenues in Rhode Island were similar to hospital revenues in Massachusetts in the solid orange. And then over the next 8 years, those hospital revenues in Rhode Island grew more slowly. They grew by 19%. They were constrained, and that was what the provision did. It constrained the growth in those hospital revenues. And you can see they grew half as fast as they did in Massachusetts, where they grew 38%. So just taking that, if the hospitals had no control over their costs, then hospitals would all be deep in the red in Rhode Island. But in fact, what happened is that that's not what took place. So the dotted lines are showing the hospital's costs in Rhode Island in the blue and in Massachusetts in the orange. And in the same way, in accordance with those constrained revenues, the hospital costs in Rhode Island grew half as fast. They grew 20% in Rhode Island versus 39% in Massachusetts. So the revenues were constrained and the costs grew accordingly half as fast, keeping that difference between revenues and costs the same in Rhode Island and Massachusetts. And we didn't see any effect on, people have studied this, there's no effect on any quality measures you can look at. In fact, one quality measure was a little better in Rhode Island. So this is just another illustration of the fact that costs are not fixed. Costs are under the influence of the hospital. Of course, this is a long run picture. In the short run, we just had a lot of inflation, and in the short run, you can't magically, reduce your cost by 10% tomorrow, but in the long run, you can. Okay, next slide. So back to how we're going to define excessive prices. We're going to focus on not the entire healthcare spectrum, but the categories where prices seem to be the most excessive. And this is a summary of the literature done by the CBO, where they looked at average commercial prices relative to Medicare in these 4 categories. And you can see that they are the highest in the hospital outpatient on the left, where commercial prices averaged about 250% of Medicare, which means 2.5 times Medicare's prices. For primary care services on the far right, they were almost the same. Commercial prices and Medicare were pretty close together. So we're not going to focus on primary care prices in this topic. And we're also going to look at drugs, which you can't put on that graph because Medicare doesn't really negotiate prescription drugs either or administer drugs. But from international comparisons, we also know that our drug prices are high. Okay, so that sort of defines the scope of the categories of care we're going to look at. And then on the next slide, we'll talk about how are we defining excessive. And this is of course very difficult, somewhat arbitrary, but a lot of people have kind of centered on 200% of Medicare as a sort of a reasonable upper bound of what commercial prices should be or could be. There's been a lot of great literature, a lot of research on this. The Committee for Responsible Federal Budget used this price point to say, 11% of hospital spending is higher than double Medicare's price. This is a pretty generous point of comparison, but this is what researchers often do. Or for example, in Oregon, they actually use this benchmark as a limit for their state employees plan. They say, we will not pay more than 200% of Medicare prices for our state employees. So there is some precedent for that. And that's the basic idea of what we're going to do, but there are some nuances. For example, for imaging, Medicare pays more when an imaging happens in a hospital outpatient department than in an office. But that's somewhat controversial. MedPAC has said, no, you shouldn't do that. You should probably pay the same thing. It's the same service. That doesn't make sense. And there's actually a lot of congressional activity that might say, yeah, we kind of agree with that. And there are bills that are considering doing that. So given that uncertainty, we're going to use 200% of the HOPD rate and 200% of the office rate. And we're going to do it both ways, just as a kind of a sensitivity. For hospital inpatient, we're going to use 200% of the Mass Health rate, not Medicare. That's partly because the Medicare rates are not always a good reflection of costs when you have maternity or pediatric services that Medicare doesn't tend to have a lot of. So it's not as important to them, but there certainly is in Mass Health. And it turns out that those Mass Health rates are pretty close to Medicare. They're sometimes higher, they're sometimes lower. That's if you exclude the teaching adjustments that Medicare makes or the DISH adjustments. And for prescription drugs, we have to do something else. we're going to compare to 120% of the average price from these 6 countries. And people have studied that. And that was actually passed by the US House of Representatives as a drug price benchmark a couple of years ago. Okay. So for each of these categories of care, next slide, please. That is going to be what I'll call the price benchmark. And where prices above that, we're going to define as excessive. So just so we're all on the same page, if there's a service where Medicare pays $1,000 and the commercial payer is paying $2,500, but our price benchmark is 200% of Medicare, that means that $2,000 is kind of the price benchmark that we're setting in this case. And everything above $2,000, that $500 chunk there on top, we're saying that's excessive spending. That's above this 200%. And we're going to tally all of that up, and we're going to show you where these commercial prices fall as a percentage of Medicare. So this case is a 250% of Medicare case. When you divide that 2,500 by the 1,000, that's 250%. Okay, so that's the setup. I'll show a few results. I want to make sure we leave time for discussion, so I won't go over them all in great detail. But these are the categories we're going to be looking at so far that we have looked at. And it's not necessarily exhaustive of all spending. This is time intensive. It takes a lot of work to find the Medicare, figure out what the Medicare price is, for example. But okay, let's move on to a few of these. So we'll start with lab tests. This is a relatively straightforward example. Lab tests are about, we spend $1 billion of commercial spending on clinical lab services. It's about 4% of TME. And here's the case where Medicare pays the same amount. They don't care whether it's performed in an independent lab or a hospital. It's the same payment. So it's a straightforward example. And about half of those labs in Massachusetts are performed in hospital outpatient departments. So on the next slide, what I'm going to show you in these is, this is a histogram of the distribution of commercial prices. And what that means is, and they're separated by setting. So if you look at the gold bars, we just found all the payments for labs in the APCD and stacked them as to where they fall as a percentage of the Medicare price. And so if you look at the gold bar on the far right, that's saying that in 11% of the cases of a lab test in 2021, 11% of the time, commercial payers paid more than 5 times what Medicare would have paid for that lab. And then you can see those are rated all the way down to our price benchmark is 200% of Medicare. You see that hashed line. And then the Medicare prices way over there to the left. That's 100%. And in a few cases, the commercial payers paid less than even the Medicare price, and that's on the far left. So adding up all those gold bars that are to the right of our price benchmark, that means that 70% of lab services were paid more than 200% of Medicare, and therefore excessive, were paid too high, at least by this definition of excessive prices. And if you add up all of that spending to the right of the price benchmark, it amounts to 23% of lab spending. So in other words, if there were magically some kind of cap at 200% of Medicare, and you could not pay any more than that, then 23% of lab spending would go away, essentially. That's what that means. Okay. We'll look at a couple more categories and then I'll close out. We looked at imaging. Imaging accounts for about 5.5% of commercial healthcare spending. In this case, again, we did that sensitivity. We're talking, our X-rays, CT scans, MRI scans, ultrasounds, things like that. It's a lot of services. And again, more than half of these occur in a HOPD in Massachusetts. And then you have 34% in offices and 10% in other sites. And the next slide, showing the distribution relative to our Medicare price benchmark. About half of those that took place in a HOPD were above this 200% of Medicare benchmark. And very few of those that took place in offices were above that benchmark. Okay, next slide. Here's just an example, and we're not doing so much of that in this cost trends report. We will later, but looking at differences by provider, I'm going to pick on mammography, which is the most common, highest cost single imaging service. It's about 10% of all imaging spending. And you do see tremendous price variation by provider and by provider type for this, where the hospitals are in the dark blue and the office settings are in the gold. Okay, next slide. Inpatient services. This one is more complicated. It's a lot of spending. It's about 20% of commercial healthcare spending. Here we just looked at the facility portion of the payment. Everything else, we also included the physician part, but because of the complication, we just looked at the facility part. And we're using, again, we're going to show results for both the Mass Health, 200% of Mass Health benchmark, and the 200% of Medicare benchmark. Okay, next slide. And you can see they're fairly similar. In this case, about a quarter of commercial inpatient stays were paid more than 200% of Mass Health's rate, and 32% were paid more than 200% of Medicare's base rate. And that's in the right tail on the right there. Okay, next slide. Clinician administered drugs. This one is, again, it's a bit complicated because there's really two pieces of how we might be paying too much for this. The provider buys the drug. Those prices are higher than you would find in other countries, just like prescription drugs. And we're not even talking about that part. We're talking about the next stage where the payer then pays the provider back for where they use that drug in care for a patient. So providers sometimes mark up the price of the drug much above what they paid for it, as they then get paid back by the payer. Medicare doesn't do that. Medicare says, look, we're going to pay you back the average cost of that drug plus a 6% kind of administrative fee. So if commercial payers are paying more than Medicare, they're paying a high markup on that drug beyond the cost of the drug. And in some cases, as you see on the next slide, those markups, those extra payments can be, 200%, 300% above the cost of the drug. And so overall, about 40% of administered drug encounters in HOPD settings, and this is really, the prices are much higher in the HOPD settings, were paid more than double Medicare's price. Okay. And then I think the last one is prescription drugs. Again, it's more complicated. We can't use a Medicare benchmark. When we use an international price benchmark, as I mentioned, of 120% of the average, our prices are much higher, and there's a lot of excessive prices in this category. And the next slide is just a few examples of some of these, and we've shown some of this before, of US prices compared to international prices for these common drugs. So I'll kind of summarize all of this on the final slide. This is just a table showing of each of the categories, and I didn't show them all, but if you look at, we're showing the spending on the category in millions in the commercial population. Altogether, this isn't all of healthcare. This is 43% of TME. This is about $10.8 billion that we modeled. We couldn't model everything. And the column in the middle is showing of that spending, what percent is excessive? What percent is over the price benchmark? And it varies. For labs is 23%. For imaging, between 20 and 30%. For inpatient stays, about 9%, and so on. For prescription drugs, it's higher. It's about half. Tallying all of this up, you get about 2.9 billion of excessive commercial spending in 2021. And again, that's just of the subset of the things that we looked at. And that amounts to about 11.5% of TME. Next slide. To summarize, that's a lot of money right there. And this is, again, a recommended focus for areas where we can spend less, or we can spend less quickly. We looked at 43% of commercial spending, found that about 12% is above these price benchmarks. And for a reference point, remember that all of primary care spending in Massachusetts is about 7%. So this is more than that. And you could spend a lot more on primary care and grow less in some of these areas. And just to emphasize again, this is part of a broader discussion of prices, of policy options, and of provider prices that will come this fall. Okay. Are there any questions, any thoughts?
David, thank you.
Sure.
David, can I start off with one question, which is, so I love the analysis here. I think it's great. One of the questions that I have is like, to the extent that I'm wondering about to what extent we should think about policies to go after outlier prices.
Mm-hmm.
And if we did that, would that just show up as, okay, fine, we've got to lower that price, so we'll raise some other price? Or, we'll agree, like, yeah, we'll get rid of the 500% DME thing here. And then instead our thing where we're 127% of Medicare will raise to 143%, and that's just going to offset that revenue. and nobody's really going to notice that little changes. Like I'm sort of wondering how does this strategy have the potential to be a kind of whack-a-mole strategy?
Yeah, that's a good question. Yeah, I'm trying to kind of leave that discussion for our, for our options paper coming in the fall, but it's hard not to talk about it now. And I totally agree.
Yeah.
And we've talked to a lot of people about this, and it's kind of a devil in the details situation. Yeah, if you just constrained or limited prices in some things and left everything else untouched, you still have some of the fundamental market leverage situations that I showed earlier, and there could be some that leverage might flow into other areas. And people have said you would probably need some kind of a comprehensive approach. You need to have some kind of overall umbrella limit or control, as well as trying to, more like with the scalpel, directly go after some of the excessive prices, which again, it's not even just the spending there, but the way in which it distorts provision of care, and the way in which it distorts the market, and the kinds of places we expand and contract when the prices are off. But that is the point that we'll absolutely be considering as we talk about options and about mechanisms. That's right.
Can I just ask one other quick question, then I'm going to turn over to Patty. In the studies on Rhode Island, which I thought was incredibly fascinating, do they indicate how the hospitals dealt with less money? Like, what did they spend less on as a result?
That's a good question. No, they did not get that deep into the underlying cost reports, and that's something that I think we ought to try to learn more about, kind of through talking to people. I'm not sure there's any specific data on that, but what did they do? What did they cut? How did they do it? I think that's an important question. Agreed.
Patty?
Yeah, this is sort of similar to your first question, David. David Cutler's first question to David Auerbach. It's interesting, this year, my husband and I are on a very high deductible health plan. And so it's really fascinating to see how much we're paying out of pocket and how much we're paying for what type of service, because we get EOBs back on everything we have. So I'm astounded by the upcoding. I mean, everything's a level 4 or level 5, no matter what. I have a $375 bottle of Excedrin that I paid for. That was the prescription after a 5-minute telephone call, telehealth call. So it may be more minutia here, David Auerbach, but how do we address the upcoding pricing? Because it is that same whack-a-mole. If you push it down and we just increase the intensity of the service and bill higher. So I think it's a real hidden problem, and I don't even know how insurers can go after providers relative to upcoding, because it's a game they seem to play about how much more detail they can put into an office visit and justify a higher level, a level 5 visit, when it really is a very routine type of service. Not to say there aren't emergency and level 5 visits, but I'm really seeing it firsthand.
It's so true. And we have talked about this in the past, and we are going to continue to talk about it, because it really is it's aside from prices. Because when we're talking about prices, especially on the inpatient side, we're talking about, well, everywhere, price for a very specific category of visit. But if you are coding visits into a higher category, a higher reimbursement category, that's not captured by prices. That is separate. And it's kind of why we try to talk about why we have this total spending benchmark, because that's the only way you can really get all in, talk about the total spending. And as we've said before, the fact that our metric for PIPs is a risk-adjusted spending measure, that's problematic when there is upcoding, because it gets basically subtracted out.
Yeah,
and
or
so,
baked in.
Yeah, baked in, subtracted out. So it's so yes, it is a hard thing to get at, and the payers do, for some cases, like very costly hospitalizations, of course, there's audits and they do their best, but they just they don't have the resources to dig into to second guess every clinical decision. So much of it they just can't get
Right.
at. And
Right.
so I don't have the silver bullet for this.
Yeah. I guess I want to say, I just don't want to miss that
Totally.
discussion
Agreed.
somewhere.
Yep, it's in there. Yep. Okay.
David, thank you. That was great.
Great.
Um,
Okay.
so I was just going to turn to that. So I was just on the upcoming meetings. David Seltz, can I turn over to you for that?
Sure. Colleen, when is our next meeting?
Hello. Yes, our next meeting is October 4th. October, yeah, and it's in October. Is that right? Yes. Our next board meeting is June 4th. And so we'll all gather back for that, June 7th. Great. So we can conclude that and move to our next presentation. We have our cost trends hearing coming up November 8th. That is a new date, rescheduled date. It'll be at Suffolk University Law School again this year, live streamed on our YouTube channel. Very exciting. Any more slides? Okay, great.
Okay, great. I'm happy to introduce our next part of our meeting this morning. But before I did, I just wanted to highlight one viewpoint on the last conversation. Professor Cutler, to your point on, well, if we just restricted kind of the outliers in the top end, would there be, an incentive to find, to increase prices someplace else?
Mm-hmm.
That may not be as problematic if where we are increasing the prices someplace else is in things like primary care and behavioral health care. If we could actually change those incentives, we may be fine not recouping all of that excessive spending, but actually redirecting some of that spending in areas that provide more value. So just wanted to put a point on that as well. So for our next part of the meeting today, we wanted to turn to another one of our priority areas for 2023, which is reducing unnecessary administrative complexity. And I'm going to turn it right over to Kara Vidal, who leads the HPC's work on this topic, to first set up the topic and our past work on this issue before introducing our guest presentation. So Kara, take it away.
Thank you so much, David. Good morning, commissioners. I'm so excited to be here with you today to talk about administrative complexity, prior authorization, and mostly, as David said, to pass the mic to the dream team that we've been working with at the Network for Excellence in Health Innovation, that's NEHI, and the Mass Health Data Consortium, that's MHDC, on a project regarding automating prior authorization. Those guests will be doing most of the presentation today, but as David said, I'll just briefly set the scene here. So as you know, at the January board meeting, David laid out the HPC's agenda for action in the first half of the year. Reducing unnecessary administrative complexity was on that agenda. And as you can see on this slide, the HPC's portfolio of administrative complexity work does span a couple of different projects. We'll focus today on 5A and 5B. So as I said, specifically on automating prior authorization, this work we've done with NEHI and MHDC. And we'll also talk towards the end about other opportunities for streamlining, simplification, or standardization. Next slide, please. Okay, great. So why is reducing administrative complexity on the HPC's agenda for action? I think this is something this group knows well, but administrative costs make up a significant portion of our healthcare spending. There have been many different estimates. Some are as high as 34% of total healthcare spending nationally. And that's one of the main reasons why our per capita spending levels are so much higher than they are in comparator countries. A lot of that spending is concentrated in the billing and insurance related activities space. That's a term of art in the administrative complexity world that really refers to the intersection of payer and provider operations. And one really important point I want to make here is that the numbers on this slide are not estimates of waste. A lot of administrative spending is necessary, it's important, but it's also in our system often driven by the fact that we have a multi-payer system who set up these different necessary transactions in their own unique ways with non-standardized processes and rules. And that introduces complexity and it introduces expense. And so if we were to be able to address some of that complexity, there would be potential opportunity not just to reduce healthcare spending, but also to reduce time, costs, and administrative burden, to allow for the reallocation of resources from some of these lower value activities, such as navigating complexity, to higher value activities. It could help us address the drivers of clinician burnout, which certainly with the workforce crisis that we're currently experiencing is a significant outcome. And it could improve the patient experience, including by reducing delays in care, reducing some of the confusion that Sasha was talking about earlier as well. So, I think there's good reason to be focused on this work. If we could go to the next slide, I'll tell you that when we were starting this work out back in 2019, pre-COVID, we wanted to select a priority area so that we could ground our conversation and our research in specifics. We did extensive outreach with board members, with other state agencies, with the market, so payers, providers, patient advocates, trade groups, the HPC's Advisory Council, other states, and importantly, the Mass Collaborative, which is a multi-industry group that works on administrative complexity issues in Massachusetts specifically. Based in part on that outreach that we did, we decided to start with prior authorization. That was a top priority for many of the groups we spoke with, but there were other reasons to select it. One is that at the time, and still today, prior authorization was getting a lot of attention in other states and nationally for prior auth reform, and I'm sure many of you have seen some of the laws that have passed nationally and in other states, for example, the Texas Mandatory Gold Carding Act. Prior authorization also has direct patient impacts, unlike some of the areas of administrative complexity that we were considering. Credentialing was one that rose to the top of the priority lists for many stakeholders, but we really wanted to focus on something that touched patients directly. And so that fit the bill here. And then finally, we were looking for an area that was exemplary of many of the complexities and redundancies inherent in other healthcare transactions here, so that if we come up with findings, if we come up with lessons learned, we may be able to apply those not only to prior authorization, but more broadly. So on the next slide, please, you'll see that after we identified a priority area to start with, we went to the literature to say, well, what can we say about prior authorization? What's already known? A lot has been written on this topic. And I want to start with a really important piece, which is the implications for spending. Really important, I think, especially for the Health Policy Commission, a spending-focused agency, to start there. There's really strong evidence that prior authorization reduces spending for targeted services. And even more importantly, in a paper that just came out earlier this year, and that Dr. Cutler, I'm sure, knows even better than I do because he's mentioned in the acknowledgements on it, those savings hold even when you account for payer and provider administrative costs. That was something that I think was not as well established and known in 2019 when we were starting this work, and was a big question mark for us. So some really important contributions to the literature recently. However, because of the complexity and variation between prior authorization processes that exists, we have efficiency and we have unnecessary spending. So there's still opportunity to do this more efficiently for the system as a whole. In terms of clinical impacts, again, here we find that prior authorization can serve important clinical functions. It can help reduce low-value care. It can help detect and avoid dangerous drug-drug interactions. And it can act as a clinical decision support tool for providers. However, again, because of the complexity and the difficulty in navigation of the multiple systems that exist, prior authorization can also result in care deferral, and in some cases, care avoidance of necessary care. And there's been some research that that's often based on inappropriate denials in the Medicare Advantage space. There's been some work done on that. And from an equity lens, there's also been some work to support the idea that the greater associated burdens, such as ultimate care delay and care deferral, can fall on groups who are known to experience health disparities and who can struggle to navigate those administrative requirements. And then finally, looking beyond the spending impacts and the clinical impacts, there's also, I could say evidence. I don't even know if we need evidence on this point, but prior authorization is a contributor to clinician burnout. And in fact, the US Surgeon General released a report calling for reforms to prior authorization to help address clinician burnout. So after we went to the literature, we talked to stakeholders in Massachusetts. And this slide documents the pain points in the prior authorization process from their perspective. I will say we cast a wide net. We did speak to a wide group of stakeholders. This slide really reflects providers, their trade groups, and patient advocates. We spoke with payers and we spoke with prior auth technology vendors. They did not spend their time highlighting to us the pain points. So just to be very clear, they're not represented on this slide here. I'd be happy to talk to some of their perspectives if that would be helpful. So what are some of those pain points that the market is experiencing? Well, for one thing, there's frustration with the volume of prior authorizations that are required. There's also, as many people highlighted to us, a lack of standardization in everything from what codes require prior authorization, how prior authorization needs to be requested, what information needs to be included, the criteria for approval and submission, and how a payer is going to communicate their decision back to the provider. We also heard difficulties on the time it takes to get a final approval and how long that approval is good for. We heard about the difficulties providers face navigating mid-year changes in payer policies. And we heard about frustrations with retroactive denials and difficulty with patient plan switching. So if a patient has an approved prior auth, they switch plans, do they need to go through the process again? And the next slide, please. Thank you. So what can be done? This is exactly where we were, I would say, in early 2020, about March of 2020, minus some of the newer excellent research that has since come out. We were just starting to talk about moving this conversation into what can be done, how can the burden be reduced, when we had to hit pause on this work, and the payers and the providers who were really helpful in providing their input and their time and their thoughts on this process obviously had to turn their attention away to the pandemic as well. So we were really excited when NEHI and MHDC approached us with an opportunity to continue this work. So they're here to talk to you today about a very specific solution, which is automating prior authorization. And I will let them give you a more fulsome definition in just a moment, but in general, automation refers to advances in technology that allow for a more seamless exchange of data directly between the payers and providers. It is not digitization, it is not just email or using web portals, it's really about that automatic transfer of information between systems. And excuse me, and you will enjoy, I'm sure, the greater clarity and definition you get from NEHI shortly after this. Really important to say that while automation is not going to address all of the pain points that we just highlighted on the previous slide, it really can improve several of them for payers, providers, and patients. There's a couple examples on this slide. I'll just highlight a few. One is that we've heard that providers often aren't sure if prior auth is even required, and oftentimes wind up submitting prior authorizations that they didn't have to submit. So by making that information immediately available, you reduce some of that work that never had to occur in the first place. You might decrease the time from submission to disposition and much, much more. So with that, I'm so pleased to introduce Wendy Waring, who's the president and CEO of the Network for Excellence in Health Innovation. She's joined by Lauren Beadle, also of NEHI. We have Denny Brennan, who's the executive director of the Massachusetts Health Data Consortium, and Dave Delano, who's the executive director of the New England Healthcare Exchange Network. And together they are a really dynamic team with fantastic expertise and insight on this topic. And I'm so pleased that they could be with you today. So Wendy, over to you.
Well, thank you, Kara. And thank you for giving most of our presentation. Kara now knows more about automation and prior authorization almost than we do. She's been a great partner, as has Kate Mills. You can see our team here. I actually look much better in that photo than I do in real life. So you're going to be disappointed when you actually see me. Next slide. This is our the collective mission and vision for both organizations. I won't spend time on that, but both of us are dedicated to improving patient care by improving quality, reducing cost, adding to the value of the healthcare system, both through interoperability and through innovation. Next slide. Here is our agenda. We will do a little bit of background. As Kara said, we will try to explain automation. At the end of the presentation, if you have technical questions, we're going to put Dave Delano on and he will answer all your technical questions. We'll try to keep it accessible throughout the conversation. Next slide. So as you heard, the burdens of prior authorization are increasing in part because the volume of prior authorizations are increasing, and in part because of the other burdens of the healthcare system elevate the annoyances that prior authorization does have. Nevertheless, as Kara acknowledged, there are many benefits to prior authorization. And we approach this project from the standpoint that prior authorization is likely a necessary part of the healthcare system. How can we make it better and less burdensome? Next slide. So this is actually our second project on administrative reform. In our first project, we gathered a group of Massachusetts stakeholders representing all sectors of the healthcare industry. And we spoke together over the course of about a year and a half about what the issues were with prior authorization. And then we did quite a bit of research on the solutions that have been identified in the literature. We presented those solutions to our group of stakeholders and we discussed each one, both the pros and the cons. In the light orange there, you see sort of the four solutions that we came up with that had a high degree of consensus. Our dark orange line, create incentives for full automation of prior authorization, had, I think, virtually full consensus from a wide group of stakeholders. So there are solutions that we would recommend pursuing next, but this project decided to tackle what would it take for Massachusetts to fully automate prior authorization within the next 2 years as a foundation for further reforms that could be pursued. And many of the reforms that you see there address some of the issues that Kara highlighted in her previous discussion, as well as the issues considered on the left-hand side of this screen. Next slide. So as we are, we're going to keep saying it, it is not a panacea, but automation as a solution has the advantage of benefiting every stakeholder in Massachusetts. And by that, we mean patients, providers, both hospitals and physicians, as well as payers. So we will, automation, as we'll go through and we'll show you, it will illustrate how these things happen. Automation will reduce delays in patient care. The AMA has just put out in March another report saying that 93% of their respondents noted that prior authorization causes delays in patient care and then may cause patients to abandon care. Automation, especially if coupled with AI, artificial intelligence can reduce the timing to 2 hours from weeks in terms of processing prior authorization. It will relieve burden and cost for providers and payers as well. So it certainly will remove friction associated with payer variation in prior authorization requirements. And in terms of responding to the documentation required for prior authorization, by automating that, it will certainly reduce the personnel and time required to process a prior authorization request. For payers, it will also shrink the unnecessary number of prior authorization requests that they receive. Right now, providers often submit prior authorization requests when they are not required, and automation will clarify when and when not prior authorization is necessary for an ordered service. And last but not least, especially from the Health Policy Commission's perspective, automation will enable us to get much better access to data that can inform further reforms of the process. So we want to have sort of an evidence-based change in the system, as opposed to sort of guessing what will work and what will not. Automation will make obtaining data much easier than it is now, which is often a manual process. And it will also standardize data elements. Next slide. So here's sort of, the Health Policy Commission has pressed us to say, well, really, what will automation save? CAQH, the Council on Affordable Quality Healthcare, has projected estimates. We did not do that with respect to the payers and providers in our system, but it is a knowable quantity with some further survey of our stakeholders, and we would certainly recommend, as we will, doing a baseline and then a subsequent look at the cost of prior authorization. But you can see that providers are projected per transaction to save almost $6, payers, a little over $3.50, and that the system as a whole will save about $449 million on PA volumes, not prior authorization volumes nationally. Next slide, sorry. So I am now going to have the pleasure of turning this over to Lauren, because she is so facile at explaining what automation is.
Thank you. So basically, just to establish a common definition, automation is really the adoption of the whole end-to-end prior auth request. So everything from the provider requesting an order or service all the way through to the payer's response. And this is done completely electronically and using a defined set of data exchange standards and technologies. So ultimately, it exhibits little or no need for human intervention, although it often will require that in some cases. And those data standards should be used by the entire community. And as Kara already pointed out, automation is not digitization. So we're not referring to the use of web portals or interactive voice responses. Next slide, please. So I'm going to walk you through this very simplified end-to-end automation workflow. So starting with the provider deciding on an order or treatment for a specific patient, they're going to want to know whether the patient is covered for that order or treatment and whether that is going to require prior authorization. So in the second step, when they begin a request for that order or service, prior authorization and coverage requirements are automatically shared between the payer system and the provider system. So assuming that prior authorization is required and the patient is covered, the payer can then begin gathering information from the provider's EMR to satisfy their questionnaire on medical necessity criteria. And then in the fourth step, the provider has the opportunity to review the data that was automatically pulled from the EMR, but they can also decide that if the data is pulled and auto-populates the questionnaire completely, that can just be automatically sent to the payer or the intermediary for processing. So that takes us to the fifth step, where the payer or intermediary will process the request and send a decision in real time back to the provider's EMR. And we can gloss over the sixth step. Sometimes the payer is going to require more information to make a determination. And if that's the case, the provider will be prompted back to the stage in this workflow where they can collect that additional information. Next slide, please. So we can look at this same workflow and also see the benefits to automation in each step. So once the provider decides on an order of treatment and starts a request for that order, they're going to receive an immediate response as to whether prior auth is required or not. So that is going to eliminate the need for the provider or their staff to have to go to an individual payer website to look up requirements, or even calling the payer to double check. And as we've said before, it'll also eliminate the need to submit a prior auth request when it's not even required. So, and then in the third step, the data needed to satisfy the medical necessity criteria is going to be pulled automatically, and it's going to auto-populate the payer's questionnaire to satisfy their medical necessity criteria. So again, the provider or their staff will not need to hunt for this data and then manually enter it into the questionnaire. In the fourth step, the documentation or the whole prior authorization bundle is submitted electronically rather than via phone or fax. So this is going to save time both for the provider and payer. The provider or their staff is not going to need to get on the phone to reach the payer and ensure that they received the documentation. And likewise, the payer won't have to field phone calls and go and hunt down faxes. And then finally, the decision from the payer will be sent to the provider's EMR in real time. So this will ultimately reduce delays in patient care, or as we've just discussed, reduce the possibility that patients will completely forgo treatment because they're waiting on a prior authorization decision. Next slide, please. So all these benefits sound great, but how do we even automate? We can do this through the use of FHIR APIs. So these are just two of the definitions we want you to walk away with. The first one, API, Application Programming Interface. I'm sure many, if not all of you, have heard this or are probably familiar with it. I like to think of this as using Travelocity. If you want to go on vacation, you have a destination in mind, you have dates that you want to go and return, and you also maybe you want a round trip ticket. So you have all of these specifications in mind, and Travelocity will go and get information that matches your criteria from each of the individual airline and hotel websites and then present that information to you. So in the context of automation, it's very similar because you're using APIs. The provider's clinical decision support API that is in their EMR will connect with the payer's API service, and they'll talk to each other and understand whether the patient is covered for that service or treatment and whether prior authorization is required. And then FHIR, which stands for Fast Healthcare Interoperability Resource, is a little trickier, but it's a framework of structured data definitions organized into resources for APIs to use. And essentially what we want you to take away is that FHIR is the standard framework for writing and using APIs in healthcare. So this method is going to give us the same level of immediacy that we would get as we're booking a trip through Travelocity. And in the context of automation, the provider can launch a Smart on FHIR app from within their EMR that will automatically pull and auto-populate data that satisfies the payer's medical necessity criteria. Next slide, please. So we are not the only ones interested in automating. The federal government is also working to advance interoperability, which specifically will include automation. So back in December of last year, CMS released a proposed rule that would, among other provisions, require all impacted payers to implement and maintain a FHIR API. And this would apply to Medicare Advantage organizations, state Medicaid and CHIP fee-for-service programs, Medicaid managed care plans, CHIP managed care entities, and qualified health plan insurers on federally facilitated exchanges. And they would be requiring payers to be ready to automate by January 1st of 2026. It is possible this could be pushed back once the rule is finalized, but even so, this doesn't give us a lot of time. And another thing we want to highlight is that the proposed rule would also call for payers to report data on prior authorization. So just a couple examples, they're looking for a list of all items and services subject to prior authorization, percentage of prior authorization requests approved, percentage denied, percentage approved after appeals. So they're looking for more than a handful of data to be reported, but as Wendy noted, this is going to be a lot easier to generate using automation. And this is also going to increase transparency into the process and help us understand whether prior authorization as automated is working and how well it's working. Next slide, please. So our project essentially gathered these stakeholders. You can see their logos on your screen. And the goal was to see how receptive they were to automating and what their requirements were for automating and moving forward in the next 2 years. So MHDC and NEHI essentially had 3 main activities that produced the recommendations that we'll share with you in a second. First, we aligned our stakeholders on a definition of end-to-end automation, similar to what I just walked you through. And we did that using a defined set of data exchange standards that Wendy will discuss in her upcoming slides. We also, through advisory group meetings, interviews, and informal focus groups, spoke with our stakeholders about any concerns they had about automating, any barriers, and then any potential ROI they saw to automating. And then finally, once we drafted our recommendations, we went back and shared them with this group to ensure that we accurately captured their concerns and that they saw that those concerns were depicted through our recommendations. Next slide, please. So I'll turn it back to Wendy, who will go through our recommendations.
So these are our recommendations, that is NEHI's and MHDC's recommendations, but we are going to, as we walk through them, we tested each one with our automation advisory group, all those stakeholders you just saw, and we'll also report on their support for the recommendations, the specific recommendations. So our first, that Massachusetts can and should take a leadership role in automation aligns not only, as you heard, with HPC's action plan to reduce healthcare cost growth and tackle critical challenges facing the healthcare system today by reducing unnecessary administrative complexity, but with work, which you also heard, that the Mass Collaborative, which represents payers, providers, and trade associations, has been doing to address administrative costs and burden. In other words, this has been a focus for Massachusetts for a number of years, and the key stakeholders, we think, are primed to pursue it. Second, because this is a complex endeavor and involves technical change and multiple activities by various organizations, we think there has to be a level of organization and coordination to improve implementation and ensure efficiency and effectiveness as we go forward. Third, implementation efforts should start now, and I'll address specifically why we should not just rely on the federal rule. So full compliance with federal directives will require at least the time allotted. And even though the date may be pushed back for full compliance, we think that by starting now, we will learn from the experience, be able to work with the federal government and the state government to do this efficiently. I will talk through what the Da Vinci implementation guides are in a moment, but there is already an automation roadmap that has been tested to a great extent by a wide-ranging industry group, and we think that that should form the basis of the roadmap that Massachusetts uses to mandate and automate implementation. And there was a great alignment around use of the Da Vinci guides. And last, we had a lot of alignment around the fact that because this involves technical change and workflow change, providers and payers will need technical and financial support in varying degrees, and we have a way that we're going to recommend that that be provided. Next slide. So moving automation forward now, we think requires that the state use legislative and regulatory authority to mandate automation based on a technical roadmap. So there are two parts of this. One is that we have to create a roadmap. Two is that we have to create legislation that mandates automation moving forward, and vest oversight authority with a state agency. And we give some examples of the agencies that could assume responsibility for overseeing the automation process. As I mentioned, we want to use the Da Vinci guidelines as a foundation for the technical roadmap, and in a couple of slides, I will explain those. The most important thing here, and this is very important, especially to the payers, the Da Vinci implementation guides do not conflict with the federal rule. And in fact, we are going to recommend some modifications of the Da Vinci guides to address specific concerns that Massachusetts payers and providers have, but those modifications come well within the bounds of the federal rule. When we presented this to TAG, you can see that almost 40% of the members, and I believe it was 21 responses, supported without reservations. Yes, with reservations largely represents the payer's view that mandates of this type are not favored. And I think the payers largely support automation as a way to improve the prior authorization process, but oppose an across-the-board mandate. We nevertheless are recommending that this be mandated in order to ensure that people move forward together. Next slide. So Kara has asked us this question repeatedly. Why should the state get involved in the automation of prior authorization? So the federal rule, as you saw, does not cover all payers. And by not covering all payers, it means that some payers will either create a separate process for their Medicare Advantage business or their Medicaid business, and may not put automation in place for all of their product lines, which will deprive providers of a significant part of the benefits of automation. In addition, we think that it will be easier for all payers to move forward together once, rather than in different phases. The automation roadmap will yield immediate benefits. So you don't have to wait till, let's say it's January 2026. By specifying technical requirements, we can ensure that providers see an immediate benefit to automation. The yes or no is prior authorization required within a 6-month period, especially with technical assistance. As we also said, the federal rules making strictures did not allow it to rely on the Da Vinci guidelines. We did have CMS represented on TAG, as you may have noticed, and they are supportive of us moving forward with the Da Vinci guidelines, especially because it will inform their further efforts. Last but not least, by mandating automation in this state, the state can also take responsibility and authority to define the data requirements that will make the benefits as well as the burdens of automation of prior authorization more apparent. And we will recommend in a few moments that the stakeholders be involved in establishing those data requirements so that everyone is aligned on what they want to see from automation and the prior authorization process. Next slide. So we've mentioned Da Vinci a couple of times. It is HL7 on the right there. It's called the HL7 Da Vinci project. It's a standards developing organization. And one of the standards they've developed is for automation. They have developed detailed guides, which are often referenced in automation discussions. And they have been testing and refining these guidelines. They are much clearer than what the federal rules are mandating, and therefore they provide a really good foundation for a technical roadmap that we would recommend group like MHDC and NEHAN spell out. So the goal there is to accelerate the adoption of FHIR standards across payers and providers. That was the goal of the Da Vinci project. This automation will build on that. Next slide. So as we mentioned, we are recommending some modification of the Da Vinci guides to address stakeholder concerns. Kara mentioned some of them, we mentioned some of them. So for example, we would require what we call a unique identifier in the response, in the request and response to a service for prior authorization. This will provide a clear record of the payer responses to a prior authorization request in the event of a claim dispute. And then we would further recommend requiring that the payer honor the response that it has provided when a provider submits an order for a service. When the payer responds to that as prior authorization is not required, they would be required to honor that response. And we would be able to identify and audit the response. We would eliminate the option of a no response there. That means that the automation process would require a yes or no, that prior authorization is required, which avoids unnecessary submissions and further communications between provider and payer. This is a little technical, but we would recommend the use of pre-fetch templates to draw information from the provider's EMR for the payer. This is to increase trust because it will contain defined elements associated with a particular payer's prior authorization requirements. And last, well, this is not last, we're just highlighting 4 of the modifications, but we would also recommend the use of structured questionnaires with what we call clinical query language. This reduces variation in manual data entry. It will also eliminate the very burdensome process that payers and providers here have been going through, which is modifying the forms, which has taken them several years to do. Using structured questionnaires in the automation process will achieve the same purpose as the standardization of forms. Next slide. So, there was why we are recommending establishing a statewide technical assistance center. You can see there is overwhelming response from the TAG for this recommendation. We recognize that we will need to, on an ongoing basis, resolve technical issues, provide guidance, and maintain consistency with the federal rule. And a statewide technical assistance center can do that. We don't think this is a complicated process, although this will seem self-serving. MHDC and NEHAN already provide a very similar function and can provide this function on a subscription basis so that payers and providers will be able to obtain services from NEHAN and MHDC that meet these goals. We note here and AHIP, the America's Health Insurance Plan, which is a nationwide association of payers, has also noted that we will need to work with ONC, the Office of the National Coordinator, to speed EMR certification requirements that support automation, especially because the providers will need to rely on their EMR capabilities in order to enable full automation. Next slide. There's clearly a need for reporting related to desired outcomes. We shouldn't trust that automation will solve all problems. It will not. But by continuing to focus on the data that inform us about whether we're meeting our goals, we will enable further reforms. So we focus initially on efficiency and effectiveness of prior authorization. Some of these reporting requirements are already contained in the federal rule. And we would take advantage of those, but may customize them to meet the state's particular goals. Opportunities to reduce unnecessary variation in prior authorization, we would recommend as a strong focus of the reporting requirements. And then we would look at savings achieved by automation and where those savings are redeployed. I know the prior presentation sort of discussed that. So next slide. We are, NEHI is, as is MHDC, sort of, our core is about collaboration among different stakeholders at our core. Both organizations are about that, and therefore we also are recommending creating an ongoing multi-stakeholder task force to ensure that we're monitoring and making recommendations on an ongoing basis to the state about the improvements both in automation and in prior authorization. There are several states that have established similar bodies of this type. We recommend either formally establishing a task force that includes as you can see, the Mass Collaborative, designees, patient and consumer advocates, and diverse payers and providers, or voluntarily urging the creation of that type of a task force. And as I said, it would provide advice, ongoing advice to state authorities on the measures, as well as recommend additional reforms to reduce administrative burden. Next slide. I think the Health Policy Commission was the staff, I can't say for the commissioners yet, but was not so enthusiastic about this, but we believe it is realistic to assume that there will be some level of financial assistance required. We did a high-level overview of what it will cost if we establish a technical assistance center for each payer and provider to adopt automation. We were really focused on the payer costs, and we think it will likely range from about $30,000 to $600,000 per participating organization to fully automate prior authorization over the course of a number of years. So you can see there, we have strong support there, and we do believe at least that the Technical Assistance Center should be established. We can then further refine the costs, and then assistance can be provided on a need-based, on the basis of need among providers and payers. Next slide. So this is sort of our summary. This is a state that can take this on and can assume a leadership role and can then demonstrate that we are addressing not only administrative burden and administrative costs, but efficiency in the system. We do have a running start. The Mass Collaborative has been working on this. We have already assembled a very strong group of stakeholders, including, I should have highlighted this, vendors or technical service companies who have been participating with us and are developing solutions that can really help both providers and payers automate. We do have a history of successful health IT implementations in this state. And we have strong leadership in the government as well as in the private sector. I should have mentioned the project co-sponsors here are our technical service providers. Cohere is located here, Z Omega, Change Healthcare, and Hook. Olive has been participating in a demonstration project with Blue Cross Blue Shield of Massachusetts and New England Baptist. So I think in the parlance of the flywheel, we have started the flywheel turning and are prepared to do this. Next slide. This is a pretty complicated slide, and so I've asked, you can see that MHDC has already put together sort of a pathway to address prior authorization. And I think, Denny, you were going to just say a few words about this.
Thank you, Wendy, and thank you to the commissioners. I'll be very brief about this. The bottom three blocks really tell you how we've organized our implementation process with a goal of January 2026 being the deadline. Whether that changes or not, we'll be able to flex accordingly. But the three stages are, we have to complete implementation planning, which includes a number of activities such as the inventory of electronic medical record systems across provider organizations, medical groups, physician practices. It also includes an endpoint directory of all the participants who would be involved in prior authorization. We also have to issue an RFP for technology services support. We envision reaching out to a number of different organizations, possibly with multiple RFPs, to support automation of prior authorization and the underlying infrastructure that supports it, which includes a number of things that I won't get into right now. We also want to complete what we call conformance criteria, which is your electronic medical record system able to participate in this automated exchange? Is your utilization management or your care coordination system on the payer side able to participate in automation? And how do we validate that and verify that so that we're working with organizations that are prepared to do that as soon as possible? And we want to have the task force convened so that we can begin to report regularly on our progress in moving to what we've circled in red, April 2024, which is really the first date where we start seeing results. And those results will be coming through the completion of a coverage requirements discovery prototype, which, as Wendy described earlier, is that first step in prior authorization that says, does this service require a prior auth or not? Research shows that almost 50%, sometimes more, of prior authorization submissions are unnecessary. That's the first step we want to be able to show to participants, to show to the Health Policy Commission and other representatives of the state, as well as the community as a whole, that this is delivering value as early as possible. This is not a process that results in some distant deliverable with uncertain prospects for success. We're focusing on delivering value, delivering returns quickly. So we have a rolling implementation process. We will be drafting in the second phase participation agreements. MHDC and NEHAN have done this a lot. We were most recently instrumental in helping the state move to ICD-10, which required a very similar comprehensive program to bring people on board, to have them sign participation agreements. In the second phase, we hope to have funding support completed, and we will complete the EPA prototyping. So by the time we reach April of 2025, we will have tested and prototyped EPA implementation for a portfolio of electronic medical record systems and a portfolio of payer side systems that will be part and central to the transaction. Starting in April of 2025, or 2 years hence, we will then begin doing what we call site-specific transaction testing in advance of production. And this is where we actually use real data that payers and providers want to begin to test, making sure that the prior authorization project process works. We're doing much more in this case than just CRD. We're doing the coverage requirements discovery. We're doing the documentation templates and rules, which is where the payer is able to extract, using those templates, the information that they need from the electronic medical record, and where we begin the process of reporting the exact kinds of results, appeals, approvals, denials, penned, then approved, et cetera, a range of reporting statistics on the prior authorization process and its outcomes, with a goal toward meeting the aligned with CMS deadline of January 1st, 2026. So I'll stop there and leave it at that. Thank you, Wendy, and thanks to all.
So our proposed next steps that can be accomplished prior to a mandate, which we hope the state will pursue, and we're happy to help with that, is to initiate a multi-stakeholder task force right away and to establish a technical assistance center. And as Denny has said, both MHDC and NEHAN are well prepared to do that. And so we think this isn't theoretical. We really think the state can make a concrete improvement in the prior authorization process, benefiting all stakeholders in a collaborative way that will be consistent and with the federal rule and actually demonstrate the state's leadership in this area. We're happy to take questions, in fact, and we'll certainly be happy to take very technical questions, but we warn you, you will get very technical answers.
That was an amazing presentation. Thank you. I guess Barbara and I are sort of jointly running this. So Barbara, I don't know if you want to, I think we should just open it up for comments or questions from the commissioners. Do you agree?
I do. It's exciting to hear what our commissioners have to say.
Well, while people are formulating, Wendy and Lauren, can I just ask you, like, what would the state have to do? Can you just give us the steps that the state would have to do? And as part of that, what Health Policy Commission would have to do or should do? And then maybe just talk for a minute about the budgetary implications for the state. And like, there are probably some short-term budgetary costs. Do we have a guess about those? And then possible ways, if you have any, to think about, okay, maybe the state in essence loans the dollars by putting them up front and taking them out down the road, like anything about that level.
So, I have, so let me try to answer all your questions, although I'm tempted to start with your last, that the financial aid, and I've been thinking about this, certainly could be provided on a loan basis, sort of a bridge to the savings that that providers and payers are expected to achieve. But what does the state have to do? So we believe that it would make sense for the state to file legislation, which means deciding, writing that legislation, and it wouldn't require writing legislation that includes the technical roadmap, but it would require writing legislation that decides what state authority will oversee the process of automation, that will delegate to an entity the ability to write the roadmap and participate in monitoring compliance with the roadmap, and then participating in then actually writing requirements through regulation, not legislation, for reporting on the automation, both implementation process and the outcomes of automation. So sort of in our head, the first thing is, and we began to do this a little bit, is writing the legislation that would mandate the automation process, indicate the state agency, and set up the structures. We would recommend setting up both the Technical Assistance Center and the task force at the same time. Does that answer your question? The budgetary implications. Yeah. So we have to dive into that. And I think we can probably, MHDC and NEHAN are prepared to come up with much more refined estimates of what this would cost. We would have to develop sort of financial need guidelines. So there probably would need to be some kind of RFP process or a loan application process where providers and payers apply to the state for financial assistance. So you'd have to develop criteria on which that would be based.
Thank you. Deb, I saw your figurative hand raised.
Yeah, thanks so much. And really appreciate the report and the discussion. I put my hand down because it sounded like Wendy had answered my question, which was to talk a bit more about the realities for providers of implementation and the costs, because I think your slide had reflected the payer costs, but it sounds like you were just saying, Wendy, that you'd need to dig into that as a next step.
We would. And, you know, the provider costs are likely associated with their work with their EMR vendors. And so that also requires coordination with the EMR vendors, what they will take on, what they will charge providers for taking that on. If ONC refines its certification guidelines, that will address, we think, a good part of it, but we would want to consider the provider's costs in the automation process, especially smaller providers.
I see, I wasn't sure, I'm not sure what order they came up in, but I see David and Maddie.
Thank you. I'll be really quick. I just wanted to build off of that prior point was on the provider side. I could imagine, our big health systems that all have Epic and, have structures in place could do this, but, for smaller providers, independent providers, primary care, behavioral health, it could be more of a burden. I wondered in terms of like testing this or in the demonstration projects, has there been, any feedback from the provider side that said, yes, this was a lot of work, but wow, we really do appreciate the benefit. And I know the providers have been, we're almost unanimously supportive of in terms of the tag, in terms of moving forward on automation, but just from a practical standpoint, as people do this, do they actually see the benefit? And maybe speak a little bit more on the provider perspective.
So there is a demonstration outside of Massachusetts that has produced a lot of data, as well as one in Massachusetts. Denny and Dave, I wonder if you could speak to that. You know what I'm thinking of,
MCG.
Yeah. So
Yeah.
Dave, maybe you can take this on.
Sure. Yeah. Hi, David. The short answer is that overwhelmingly providers like the way this works once it's automated. Nehan did a demonstration project back in 2014, goes back a ways, but it was called TTAP. It was implementation of a prototype project there. And we were able to achieve 82% touchless prior authorization between provider and payer, meaning no human intervention, just computer, completely automated. And when the prototype was over, we said, okay, time's up, prototype's over. The providers were like, please don't take this away. Let us keep it. It just makes their lives easier, better, more streamlined, faster, integrated with their EHR workflow. The Da Vinci guidelines take all that into account in terms of the detailed workflow. In fact, Epic sits on those calls. You mentioned Epic, and they've been helping guide that sort of, workflow enablement process within the EHR environment so that it doesn't disrupt providers' workflow or add any additional burden. It reduces the burden and makes it simpler for them. So, all thumbs up there is what we're hearing. But, yep. Any other comments? Danny, do you have any?
No, that covers it, Dave. Thank you.
So I have Maddie, and then I see Barbara's hand up after that.
Hi, thank you. That's was pretty much a lot of my question. I wanted to know, like, turnaround time that it would take. I have a prior authorization due, and I'm just, I don't have the time. So I'm wondering what the turnaround time is for that. What was it before and what is it now for most?
Yeah, no, in the demonstration projects that we've seen, Dr. Castillo, is that it's almost real time. I mean, we actually were able to achieve real time turnaround time. So when it's fully automated, as the ones I was describing, we were able to get 82% fully automated in our demonstration project. There's no human intervention. The computers do all of the work. It's just a matter of getting the transaction from one end to the other and then back. Near real time is how quickly that occurs. When human has to get involved and do some review or collect additional information to make a clinical decision on that, obviously that takes a little bit more time. But even in those cases, because of the automation and the ability to exchange electronic information versus the sort of normal way of doing it through paper, fax, portals, and other methods, which just takes so much longer than these integrated workflows that we're seeing, even though there's human intervention required in some of the more complex cases, the turnaround time is still greatly improved over traditional methods. And even in the CMS rule, we're seeing that they're requiring a reduced turnaround time from the current standards for the CMS proposed rule. And we would propose those types of reforms as well that could come out of automation. Once things are automated, you can then start to mandate things like, okay, turnaround times now need to be reduced to this and this and this, and slowly ratchet those down as things improve over time.
That's excellent. Thank you.
Sure.
Barbara.
Thank you, David. My question has to do more with what happens with denials. Is there data yet that shows whether the incidence of denials based on a particular diagnosis is affected by this process, number one? And number two, if there is a denial, is there an automated referral to a human being to take a look at that? Or how does the denial process work, I guess, is the broader question.
That's a great question. And I don't have any data on the denial impact here, honestly, yet. Yeah.
Okay.
Yeah, go ahead.
One
go ahead.
thing, we don't have specific, but we do know that many denials are issued. I think it's, I can't remember now the percentage, but it's close to 50%, or it's high, of denials result from inadequate documentation. And so the theory here is that if the documentation is pulled automatically by the payer from the provider, inadequate documentation goes away as a reason for denial. So I was hoping Dave did have some data on that, but we think that automation will very significantly, and there was just an article in the MedTech News. I just read this article. I think McKinsey has taken a look at this. The denial rates will go down because documentation in response to a prior authorization request will be improved. In terms of your other question about, will a human review this? Automation will not affect the appeals process per se. Down the road, it may, but there is still going to be an appeals process essential for looking at denials. And the data that we're proposing would be produced would include, where are the denials occurring? We would be able to see are denials occurring more in one area than another, and what's the variation in denials, so that we can dig into that, for example, with a group like the task force to reform that.
Great. Thank you. That's all very helpful information. Appreciate it.
But Wendy, can I ask you a question? Just because this seems like such an obvious thing to do. If you were going to make the case the other way, like what would you, if you were going to say, okay, state, what could go wrong? Or, why would you not do it? What would you say?
Oh, I think the case is, that as having come from a provider organization, there is a long list of things that both payers and providers are trying to do that involve technical change. And they are going to say, this is just one more thing we have to do. But as Denny pointed out, this will have an immediate, relatively short-term benefit. And I think that with the right kind of technical assistance, we can remove a lot of that hesitation to get started and move forward in that direction. And that's why, in part, we're saying you really do need to centralize technical assistance so that people can learn from one another, coordinate, and achieve immediate benefits. So, but I think it's the, oh no, not another thing in healthcare. What do you think?
You know, I mean, to me, it just seems like a no-brainer. But then in light of that, it's interesting that, 95% of your panel was saying, oh, no, not another thing, but please make this be one of the things that we do. Right. So, maybe there's some other things that they want us not to be doing.
Right.
That they are, but this is clearly one that people like.
Yes.
Yeah. Well, and obviously with the federal rule coming too, that's a huge influencer on opinion, I believe.
Well, I want to thank the team from NEHI and MHDC for the presentation and for the partnership and collaboration over the past 2.5 years at this point, and for this great conversation. We had hoped to spend even a little bit more time today discussing among the board members and commissioners about kind of potential next steps, both with this opportunity on automation, but also additional opportunities to optimize prior authorization and perhaps other areas of administrative complexity that the HPC would want to focus on. I think in the interest of time, I'm going to move that dialogue and conversation to our June board meeting, so we can dive in a little bit more about what the HPC's roles and next steps could be as we consider legislative policy recommendations. I would note, and Wendy noted this on their slide, there are a number of legislative proposals that were filed this year. There's a lot of interest in this topic, and many are looking to the HPC to provide guidance and leadership about how the state could move forward on this opportunity and others. So we will come back to that conversation on June 7th. But again, thank you, Wendy. Thank you to everyone who presented. And we look forward to a continued dialogue and conversation.
Thank you. It's been great working with you.
Thank you.
Thank you. That was fantastic. David Seltz, I believe our committee has overstayed its welcome. And
as it often does, but we will move forward to our final portion. Thank you, Professor Cutler, for helping to moderate and co-host that panel. We're going to move forward to our final portion of today's meeting, which is the meeting of the Care Delivery Transformation Committee, and I will turn it over to Chair Barbara Blakeney.
And David, do we just have to officially say the words, we adjourn the MOAT committee? Do we have to officially do that?
Sure.
Okay. All right, so we will officially adjourn then.
Thank you.
Then David, does that mean that I have to officially call this meeting to order?
It is the first agenda item.
Let's call the meeting to order. And in the interest of time, just let me invite David or Deb if there are any opening comments that you would like to offer. No? Okay, thank you. Then our next item is to approve the minutes. Are there any additions or corrections to the minutes? Hearing none, then may I have a motion to approve?
So moved.
Thank you. Is there a second?
Okay.
Thank you. Colleen, over to you to call the vote.
Absolutely. And we'll start with you, Madam Chair.
Approve?
Commissioner Cohen,
Approved.
Commissioner Castiel,
Approved.
and Undersecretary Sung. Thank you. Back to you, Madam Chair.
Thank you, Colleen. Our first item of business after that is the annual report of the Office of Patient Protection, their 2022 annual report. And this is an intensive piece of work that the agency does. It doesn't necessarily reach the board as frequently as the other items do, but it's a critical piece of work that the commission does. So let me turn it over to Kelly. Who am I turning this over to?
You are turning it over to Nancy Ryan, Commissioner Blakeney.
Thank you. Nancy, where are you? There you are.
Thank you so
Welcome.
much. So good morning, and as Commissioner Blakeney said, I'm here to present findings from the 2021 Office of Patient Protection's annual report detailing our work assisting consumers with healthcare access issues. As a reminder, OPP has 4 primary services offered to consumers. The first is allowing for the opportunity to purchase health insurance for consumers who missed the open enrollment period through an open enrollment waiver. The second is regulating and administering health insurance appeals for consumers who have been denied coverage by their health insurance company. The third is regulating and administering appeals for patients of accountable care organizations and risk-bearing provider organizations who've been denied a referral or other service by their provider. We also operate a hotline and answer online inquiries and emails addressing a wide number of patient concerns. So the 2021 OPP annual report details work in that year, and I've included a few quick snapshots from the report to present here. So this first slide details OPP's first consumer service, which is issuing waivers for those consumers who would like to enroll in health insurance and who unintentionally missed the open enrollment period. In 2021, OPP received a comparably low amount of waivers in 2021 due to the fact that consumers could access insurance for most of the year without the need for a waiver. Open enrollment was extended in 2021 through May 23rd and opened back up again in November, rather than just continuing through January, which is typical. This was a continued protection for consumers due to the ongoing pandemic. So the 2021 numbers were smaller than usual, but really on par with 2020 when open enrollment was also extended for those consumers. As usual, as you can see here, OPP approved the majority of waiver requests. We really deny waivers sort of when there's missing information, the person already has insurance, or the person had the opportunity to purchase insurance, but didn't do so and don't really have a good reason why they didn't do so. So OPP works closely with the connector to assist consumers enrolling in health insurance and to troubleshoot sort of all sorts of enrollment issues that consumers may face. This is an area of sort of heightened collaboration with the connector. The following few slides detail the health insurance appeals process. So this slide deals with the reporting from insurance companies on their internal appeals process. Insurance companies reported receiving over 13,000 internal appeals from members in 2021. This number is higher than in 2020, which would be expected based on sort of the pandemic sort of lessening a little bit in 2021, people having more access to healthcare services. This number represents all appeals received, not just those related to medical necessity by the health plans, as a point of clarification. And as you can see here, 50% of consumers who submitted an internal appeal to their health insurance company received coverage as a result of that appeal. So it's a really important consumer protection here. The next slide details those consumers who were denied at the internal appeal coming to an external review. So we had 232 requests for external review at OPP in 2021. The external review is the second level of appeal that allows consumers to have their case examined by an independent healthcare professional contracted with the Office of Patient Protection. As you can see here, consumers were granted the requested coverage in 54% of the 156 eligible cases processed by OPP in 2021. These are numbers that are pretty similar to previous years. On this slide, you can see a breakdown between external appeals related to behavioral health services and those for medical surgical services. The annual report goes into quite a bit of detail into the types of reviews that OPP processes and their outcomes, including sort of a breakdown within each of these categories to more specific services. But just as a quick snapshot on this slide, you can see the breakdown of 84% behavioral health cases resolved in favor of the patient, and 50% of the medical surgical cases resolved in favor of the patient. It's worth noting that OPP received fewer behavioral health external review requests than last year. This is a continuing trend. We really, only saw in 2021 19 eligible external reviews related to coverage for behavioral health care in 2021. We're receiving sort of fewer and fewer as years go by because of various other protections that are afforded to consumers related to behavioral health treatment. So, want to sort of highlight this slide, but also make a note that the behavioral health related external reviews are quite small that we received. So this slide shows the outcomes of internal appeals processed by risk-bearing provider organizations and accountable care organizations. This is a process where patients can challenge decisions by their provider organization related to referrals, type or intensity of services, timeliness of services, or other concerns related to RBPO or ACO financial incentives. The first level of appeal is internal to the provider organization, just as in the health insurance appeals context. As you can see, the majority of internal appeals were upheld by the RBPOs or ACOs. In terms of types of appeals in 2021, nearly all, 94% of RBPO ACO internal appeals were related to referral restrictions. And on the external appeal side, during 2021, OPP received 21 requests for external review from patients of RBPOs and ACOs. Of those 21, 19 were eligible for external review and they all concerned referral restrictions. And in all cases, the external reviewer contracted with OPP upheld the decision of the RBPO ACO, deciding that the requested referral was not likely to produce a more clinically beneficial outcome for the patient than the referral recommended by the RBPO or ACO. The next slide just gives an update on our consumer assistance and information. So OPP assisted 1,267 consumers via our hotline in 2021. This is sort of a typical amount of calls that OPP receives. This is after a dip in the amount of calls we received in 2020. I've also included a quote from a consumer who requested assistance from OPP in accessing coverage. It said nice things about our office and how we assisted them. This person is one of many people with whom OPP interacts every day, where we try to understand what people are going through and assist them, to the extent possible. Of course, we can't assist everybody, so we have sort of a wide referral network and provide information and resources to all consumers, even if their needs don't fit quite within our office. Next, I just wanted to give a brief update on our continued work in 2022 and also in this year. 2022 represented a year really when OPP was sort of fully back to normal in terms of the amount of consumers that we served. We saw an uptick in call volume and a return to our usual amount of waivers because open enrollment was not extended in 2022. We processed over 1,300 open enrollment waivers in 2022, and we also saw an uptick in health insurance external reviews received as well. In 2023, we continue, again, all of the work of OPP. The board has been fully briefed on the update to our regulation that was effective on April 28th. And another big update from this year is the Mass Health redetermination process, where Mass Health must evaluate every member's eligibility for Mass Health after a 3-year hiatus from such determinations during the pandemic. So to ease this transition for people, the connector and DOI have created an extended special enrollment period from April 1st of this year through November 23rd, which then is the regular open enrollment period through the end of the year. This will reduce the need for an open enrollment waiver for many people who may lose coverage as a result of no longer qualifying for Mass Health. So OPP is following this process closely, but due to this important consumer protection by the connector and DOI, we do not anticipate seeing an uptick in waivers due to the redetermination process. And as usual, we continue collaboration with other state agencies on the Mass Health redetermination issue and sort of other issues impacting OPP consumers. So that's the sort of high level update with more information in the report, but I'm happy to take any questions.
Thank you, Nancy, for that report. Are there any questions for Nancy? Marty?
Thanks, Nancy. I always appreciate the annual report, plus the great work that the Office of Patient Protection does. On the diminishing number of behavioral health appeals, could you just give me a sense of those continuation of service, or is it a level, mostly level of care appeals?
I think this typically we do have sort of mostly residential or inpatient on the behavioral health side. This year in 2021, we actually saw sort of an uptick in outpatient. So I think that would be continuation of services. But you know, still, I think the residential and the continued sort of inpatient would be more level of care determinations. But we did see this year in 2021 a change from sort of majority relating to residential and inpatient treatment to more relating to continued sort of outpatient therapy and other outpatient services.
Great, thank you.
Thank you, Nancy. Are there any other questions for Nancy? Hearing none, then Nancy, thank you so much for the work that your team does every year. The patients needing help and support benefit every time they are able to reach your program and to get the assistance and help that they need. So on an ongoing basis, on behalf of the commission, thank you.
Thank you.
Okay, let us move to related activities and an act addressing behaviors to care for mental health. Kelly.
That is actually Nancy again, so I will turn it over to her.
Nancy, you're hitting the trifecta here.
Thank you.
Yeah, please,
I'm back
please
again.
continue. Yeah.
on a different project, but so in 2022, Chapter 177, also known as the ABC Mental Health Act, gave the HPC several new responsibilities. So today I just plan to give a brief update on the mandate to develop a report on behavioral health managers. Behavioral health managers in this context means behavioral health vendors or carve-outs. So those are organizations that health plans contract with to manage some or all parts of their work related to behavioral health services. So I can go on to the next slide. So as you'll see here, the HPC, in consultation with the Division of Insurance, is tasked with analyzing the effects of behavioral health managers on accessibility, quality, and cost of behavioral health services in Massachusetts. As stated in the legislative mandate, we are tasked with analyzing the services provided by behavioral health managers by public and private payers and review oversight practices by other states that may differ from the sort of limited oversight in Massachusetts. We began work on this report last year. So far, our work has consisted of interviews with carriers and behavioral health managers and state agency partners. HPC staff is also reviewing health plan accreditation materials received from the Division of Insurance, performing legal research, and exploring qualitative and other research that may be useful to the report. It is HPC staff that is performing this work, and there's a combination of research and cost trend staff, myself, and other members of the legal team who are performing this work. So just wanted to give sort of a brief update on that, and I'm happy to answer any questions on our work so far.
Thank you, Nancy. Are there questions? Okay, Nancy, thank you very much. It's important work and I appreciate getting the update.
Thank you.
So now we are going to our investment programs and a mid-cycle evaluation, mid-cycle update. So Kelly, is it your turn now?
It is now my turn, although Nancy's a hard act to follow.
Okay.
So good afternoon, commissioners. I am pleased to be here today with my colleagues, Catherine Harrison and Taylor Bungo, to, as Commissioner Blakeney just noted, provide an update on the status of the HPC's strategic investment programs. Next slide, please. So to put today's discussion in context for you, we're going to focus on the 3 currently active investment programs, MassUp, C4SEN, and Beside. Most of you will know something about those programs, although we will provide a quick overview of each to refresh your memories. But what we hope we can focus on today is a little bit less on the background and design and more on what the programs are actually doing. What they've accomplished, and occasionally where they've struggled, and also some of what we've learned along the way. Together, these programs represent something of an evolution in our investments. They're smaller than some of our earlier programs. They're more targeted. And with direction from the legislator, they often focus on priorities in addition to or other than reducing healthcare costs. These changes have forced us to adapt in a number of ways, including how we think about impact and value. And of course, there was COVID, which demanded a whole level of operational resilience and flexibility, some of which we'll talk about today. So as 2 of the 3 of these programs enter their final lap of implementation, with the 3rd, Beside, not far on their heels, we are now in a position to do some early synthesis of what we've learned and identify some priorities for future exploration that we'll share at the end of the conversation. But before we do that, let's dig into the programs a bit, and I will start by turning it over to Catherine Harrison for MassUp.
Wonderful. Good morning, good afternoon, commissioners, and thanks for the introduction, Kelly. So the last time we spoke with you in depth at all, commissioners, about MassUp was back in February 2022. And those who were with us at that point might remember that we had a great guest presentation from the group out in Hampshire County detailing the work that they've been doing to establish a food policy council. But today, as Kelly's just said, we want to come back and give you a bit of a more general overview of what the partnerships have been up to. We're now just less than 4 months away from the end of the official implementation period. So there's been a lot going on that we're excited to share with you. Just as a very brief refresher, MassUp actually began as a conversation across staff at a few different state agencies, all of whom were working through, the various levers and mechanisms that we have to try to improve collaborations between health system organizations and community-based organizations to, more holistically and better address the overall needs of their patients and communities. So this interagency group, I just want to, give credit, really helped design and provide input into what ultimately became the MassUp investment program. Next slide, please. And as you'll likely recall, this investment program is all about supporting cross-sector partnerships. So partnerships that include a healthcare delivery organization and other community-based organizations to address one social determinant of health in their community. So MassUp is really focused on what we think of as or call upstream work, meaning, trying to actually change community level conditions that have a major impact downstream on people's health. So this is an unusual program for the HPC, nothing like it really in our past. We're not talking about healthcare services here or healthcare delivery. It's really, thinking about these more social factors. And thinking about the role of healthcare organizations in a different way, more as community partners and collaborators than as providers of individual services. So the 4 funded partnerships are shown on this slide, and each was granted up to $650,000 for a total of 36 months of work, and that began in September 2020. And again, just in terms of state agency collaboration, I just want to note that the MassUp investment program is administered by the HPC, but in close collaboration with the Department of Public Health, who are contributing some funding to the partnerships. They're conducting an evaluation, and they're spearheading some of the technical assistance for the partnerships as well. So with that as background, I'd love to give you a flavor of what our four partnerships have been doing. And on the next slide, you'll see a lot of text here. And I should say that, you know, each of these partnerships has a very detailed implementation plan that has guided their work and reflects, you know, the combination of very specific factors in their communities that they want to change and that they're focused on addressing in order to deal with the particular social determinant that they've focused on. There is no way that I can do justice to the details and the substance of everything that they're involved in the brief time that we have today, but I did just want to highlight a small number of things that they have accomplished or activities that they have ongoing, just to give you a flavor of the kinds of work that they are achieving. So I'll start with the Hampshire County Partnership, which includes Cooley Dickinson Hospital. And since successfully launching a truly resident-led food policy council last January, they've continued to grow in membership and expand their overall network in the community. At last count, they had 15 working groups and more than 50 community residents participating in leadership roles in decision-making about how the Food Policy Council should pursue its mission. And I'll note that they report having staff from the offices of 2 state representatives and Congressman McGovern engaged in their working groups. So they're really reaching not just the local community, but they're making, they're making waves among policymakers as well. The overall mission that the Food Policy Council has defined is to cultivate shared governance and a county-wide network that builds the power of community voice to make food policies more equitable, honor diverse cultures, and help local food economies to flourish. It's a lot in that statement, and I really wanted to share it verbatim with you because I think it really speaks to the breadth of what they're trying to do. Among the many sort of activities and levers that this Food Policy Council is engaging toward their aim, one of the things I think is really interesting is that they're using some of their MassUp funding to themselves become sort of a granting organization. So they are giving small sums of money away through an application process to local organizations that are doing work aligned with the Food Policy Council's goals. So they've now granted close to $100,000 to support a wide variety of projects, including community gardens, various wellness programs, produce markets, food distribution programs, as well as a resident storytelling project, among many other things, all of which are oriented toward food justice, food security, and very importantly, community leadership, which really is a hallmark of this particular partnership. And I think it's just interesting that in that way, the council really has become not just a source for generating ideas about what they'd like to see in terms of change in their community, but they've become an institution through which resources are actually being allocated toward those goals, which is pretty neat. I'll talk next about MassUp Springfield, which is the other MassUp partnership that's focused on food insecurity. And in contrast to Hampshire County, MassUp Springfield or the town of Springfield really already had a well-established Food Policy Council when they joined MassUp. So, they started at a very different place. And under MassUp, I would say their work has focused quite intentionally on the intersection of racial justice and the food system. They've done a lot of work to both increase the effectiveness and uptake of current food-related and food security programming, and to advocate for policy changes in state and local food policy all around and designed to increase the equity of those programs and policies. So for one thing, they focused a lot on increasing enrollment of Springfield residents in the Massachusetts Healthy Incentives Program, or HIP. They've been training and using Mercy Medical Center community health workers and undertaking a lot of other outreach efforts to raise awareness of HIP and to help people actually enroll. And they've also worked with a number of retailers and created local markets where HIP users can actually access fresh produce and use those benefits. They now have markets in place at Mercy Medical Center, as well as at Square One, which is an early childhood education provider and one of the partner organizations in MassUp Springfield. Another interesting thing that MassUp Springfield has underway, they've launched a photo voice project which involves training neighborhood youth to collect stories from the people in their communities about the local food environment. And this is all sort of designed to bring that storytelling aspect to the policy level and to try to drive change through that kind of advocacy. And speaking of policy advocacy and sort of policy activities in Mass Up Springfield, they've had some really tremendous opportunities to participate also in federal level conversations about food insecurity, including over the past year, a visit to the White House for its recent conference on hunger. So this group really has leaned hard into upstream work, even while I should say dealing with some very immediate crises in food insecurity related to the pandemic in Springfield, which certainly posed great challenges for them and their community all during this time. Switching over to the two partnerships that are focused on economic mobility and stability, I'll start with the Cross City Coalition, which includes Mass General Hospital and several community organizations across the cities of Revere and Chelsea. The Cross City Coalition has really honed in under this kind of economic security and mobility umbrella on two specific areas. And one of those is workforce development. And they've done a few things in that domain. First of all, the Cross City Coalition partnership includes several organizations that are direct service providers in the community, particularly in job training and career coaching programs for the local residents. And recognizing that these different organizations that are all part of this coalition are probably touching some of the same individuals at different points, one of the things that they've been able to do under Mass Up is to work together to create some standardized operating procedures and a client referral process between them to kind of streamline and better serve the community. The Cross City Coalition also has developed a written definition and kind of a fleshed out concept of what a good job looks like in their community. So they've actually sort of written up a working paper that talks about things like what a livable wage should be, talks about benefits and worker protections that should standardly be offered, expectations for upward mobility in a job, those sorts of things. And this is something that they can now use to raise community awareness of good entry-level jobs and available career pathways, and also to guide conversations that they're having with local employers to promote those kinds of employment opportunities. Another step they've taken is that they're convening a small focus group of community residents to review some existing data on the local labor market and find out what residents see as the biggest barriers to gainful employment. And this is all to help inform their job training and other supportive programs in Revere and Chelsea. The second area that the Cross City Coalition has really delved deeply into is childcare. Understanding that lack of access to affordable childcare can be a major barrier to employment. And they've been connecting with and helping organize home-based early childhood education providers into a community of practice to really get to know their needs and challenges and help them access local resources. And that group has been doing some local policy advocacy, particularly regarding some ordinances in Revere that are relevant to running that particular type of business. And finally, I'll say a few words about HEAL Winchendon. So HEAL is also working on improving economic and social vibrancy, if you will, in their community, in their town. And they're really going gangbusters as well, with lots of projects under their core focus areas of economic empowerment, social inclusion, and healthy food access. They are really trying to make the town of Winchendon a place where people want to come, people want to stay, and where people can really thrive as residents. So this partnership includes Haywood Hospital and many other organizations. It's been in place for a long time, but participation in Mass Up really has helped them build out this economic empowerment piece in particular. So in order to help expand economic opportunities in Winchendon, especially for residents who may be of lower income or of color, HEAL has supported a group of local artisans to create a dedicated maker space in town that has the benefits of providing access to some shared equipment as well as training to support these local makers as they start their own businesses. They've also created a shared community commercial kitchen for farmers and business owners to be able to have access to commercial grade kitchen equipment that meets town health and safety guidelines and acts as a central location for food distribution. They're also working toward greater economic vitality in Winchendon through the introduction of a new community grocery store in town. So Winchendon lost their only grocery store before the MassUp grant, and since then, Heal has been really involved in this effort. They've secured a letter of support for this project from the local Board of Selectmen, and they're working toward having an architectural plan, a site scope, and a business plan prepared by the end of fiscal year 23. This partnership also has created really a wonderful relationship with the Winchendon Community Action Committee, which is a nonprofit direct social service agency that really now has opened its doors to be a venue for more economic empowerment services sponsored by HEAL, including financial coaching. They now also physically host a place called the Sunshine Cafe, which is a teen-run business started by students from a couple of local high schools that are involved in HEAL's Youth Changemaker Leadership Program. And this is a program that's really designed to address, a lack of belonging, lack of jobs, and decrease in mental health in Winchendon. And these youth leaders through the Sunshine Cafe and other activities are learning skills like how to run a business, customer service, money management, and sourcing local products. So lots going on across these 4 partnerships, and even more that I really don't have time to mention now. So on to the next slide. Let me just take 1 minute to reflect that while the partnerships have all of this stuff going on behind the scenes, we at the HPC and DPH are working hard as well to support them. And just to mention a few things very briefly. We've been able to process payment requests from the awardees of about $1.2 million. I'll note that a number of the partnerships do have some funds left unspent at this time, and we are planning to offer no-cost extension to interested partnerships so that they can continue to work and spend down some of their resources before the end of the calendar year. We've been supporting them through a variety of peer learning and technical assistance opportunities, including 9 hour-long open forum discussion sessions on a variety of topics. We've also hosted 6 longer learning community sessions with expert speakers and workshops, a chance to engage in sort of deeper learning. Speaking of learning, we're collecting a lot of information from the awardees, both for evaluation purposes and to support learning and dissemination outputs. More to come on those areas in particular, but I think suffice to say, while the information that's coming out of MassUp is complex and sometimes hard to translate simply for folks who are not deeply engaged in it, we think there's a lot of learning that can come out from this program, and we're very excited to do more sharing about that in the coming months. So finally, on my last slide, I will just point out, oh, there's one more here. So just to bring a little bit of humanity to this is a photo from Tower Hill Botanic Gardens, where at the end of April, we hosted our very first in-person event for MassUp. This was a learning community event. So you'll see a lot of faces here from across the 4 partnerships, as well as some HBC and DPH staff and expert facilitators. And that is more or less the end. The final slide here is just the timeline with some key dates between now and the end of the year. As I mentioned, implementation is up at the end of August, but with no cost extension, some awards will continue through the end of the calendar year. And between now and then, it's really about doing our final rounds of data collection from the partnerships and getting ready to turn in earnest to working on our evaluation activities in 2020. So thank you so much. If we're ready to move on, I will turn it right over to my colleague Taylor Bungo to talk about C% and beside.
Catherine, just before we do move on, I just want to, as an old community organizer, it's easy to miss the empowerment that happens in programs such as this. It's easy to miss the individuals there who are learning with community and learning about organizing and learning about getting things done that they need in their community. It's easy to overlook that. And so that's what I love the picture that you put up, because it talks about the people who have been invested. And of all of the things that we think about with this kind of investment from us, engaging communities across the country to learn to do this, to become self-sustaining in their knowledge and their enthusiasm. I don't know how you put a dollar value on that, but it's so very exciting to watch. So congratulations and thank you. And with that, I agree. Let's move on.
Thank you so much.
Great. Thank you so much, Catherine. And good afternoon, commissioners. I'm excited to continue sharing updates about our investment programs, beginning with our cost-effective coordinated care for caregivers and substance-exposed newborns, or the C4SEN investment program. Previous HBC investments have focused on access to addiction treatment and perinatal support up to 6 months postpartum. And so C4SEN was designed to address a need for support 7 months to 12 months postpartum. So in April of 2021, the HBC awarded $1.5 million across 5 hospitals to improve the quality of care for substance-exposed newborns and their caregivers. Core components of the 24-month program include coordinated medical and behavioral health care, connection to early intervention, support to address health-related social needs, and the provision of care that is free of stigma and bias. Next slide, please. So the 5 C4SEN awardees have accomplished quite a bit over the last 2 years of the program. A number of strong community partnerships have formed, including Bay State Franklin Medical Center's collaboration with Community Legal Aid and Berkshire Medical Center's partnership with the local family court, sheriff's office, and FQHC to expand their program's reach. Teams are also continuing to adjust their workflows to optimize program performance and accommodate staffing changes. South Coast Hospital has made quality improvement adjustments to ensure eligible caregivers are not missed, while also incorporating peer recovery roles into the emergency department. In addition, programs are addressing the health-related social needs of their caregivers and their infants, which is a core component of the C4SEN program. South Shore Health, for example, continues to provide diapers, pack and plays, and even a parenting resource library to support the families. And finally, as stated earlier, there were originally 5 operational programs, which included Mercy Medical Center. Mercy had an ambitious program that relied heavily on partnerships with Providence Hospital and Activate Care, which is an IT platform. Unfortunately, Providence Hospital was sold, and the partnership with Mercy never came to fruition. And shortly thereafter, the Activate Care technology partnership also fell through. So considering that both of these aspects were pillars of the program, it was really difficult to pivot to something different. And so after some thoughtful discussion, the HPC and Mercy team mutually agreed to end the contract for their C4SEN program. But we parted as friends, and we look forward to future opportunities to collaborate. Next slide, please. The C4SEN program has spent a little over $700,000 as it nears the end of its contracted implementation period. 2 awardees, Berkshire Medical Center and South Shore Health, will be extending their implementation period with a no-cost extension due to unspent funds. And meanwhile, as the clinical program operations wind down, our program evaluation activities continue to ramp up. The HPC is contracted with JSI to conduct patient experience surveys and interviews. And we're collecting additional qualitative data inputs and quantitative data to document both enrollment and engagement. In addition, the C4SEN program team has made significant investments in supporting shared learning across the cohort. Throughout the program, the C4SEN team has hosted 4 peer learning events focused on everything from health equity to process and quality improvement to early intervention referrals. A spotlight featuring South Shore is under development, and we're excited to invite a summer fellow to join our team to undertake additional learning and dissemination opportunities for the program this summer. Next slide, please. Here's a brief timeline that shows that the program implementation period will be wrapping up for most awardees this summer, and we're looking forward to an evaluation report for the program expected by May of next year with our contractor, JSI. Next slide, please. So now we'll transition to our most recently launched investment program, Beside, or Birth Equity and Support through the Inclusion of Doula Expertise. And you may notice the next few slides are a little bit lighter in terms of content, and that's simply because Beside is earlier in its program investment cycle compared to the Mass Up and C4Send programs, which are both nearing the end. So in September of 2021, you'll recall the HBC approved funds to award Bay State Medical Center and Boston Medical Center to address inequities in maternal health outcomes and improve the care and patient experience of Black birthing people by increasing access to and use of doula services. The two awardees are a little over halfway through their 21-month implementation period, and the programs are designed to increase the number of Black birthing people offered doula services, improving the quality of the perinatal care, supporting a culture of mutual understanding and respect between doulas and hospital staff, and also embedding principles of racial equity and cultural humility. Next slide, please, as I dive into a little bit more detail on some updates from each of the awardees. So Bay State Medical Center is using Beside funding to set up a new doula program in partnership with the Springfield Family Doulas organization. This new program achieved great success in the first year, and they actually met their patient enrollment goal with considerable time left in their implementation period. So to ensure the team was able to continue patient services, the HBC awarded additional funding, allowing the Bay State team to increase their target from 30 to 50 Black birthing people. The team also continues their work addressing racial disparities with the OBGYN Racial Disparities and Health Equity Committee meetings. The Boston Medical Center team has a long-standing doula program called Birth Sisters, and they've used their Beside funds to expand their services with a specific focus on Black birthing people. Similar to Bay State, the BMC team has recently formed an advisory committee of doulas, midwives, clinicians, and OBGYN leadership to address bias in labor and delivery. BMC has felt the effects of our healthcare system's workforce challenges and made considerable efforts to learn about the evolving needs of the doula workforce through surveys and dialogue. And in response, they're making adjustments to pay structure, caseload assignments, and staff support. And as you can see across both programs, we're excited to say that 37 babies have been delivered as part of the Beside program, and we're looking forward to many more. On the next slide, I'll do a quick highlight. You'll notice that the Beside program has a little bit of a lower spend rate right now of $65,000 to date. There's a couple reasons for this. The payment for doula services is tied to doula visits, with a larger sum paid for the birth, which happens later in the patient's program experience. So as a result, the payments for doula care are backloaded. In addition, there's some administrative delay between the time that awardees submit for a request for reimbursement and the time that the check is actually sent. On the evaluation front, the Beside team is also contracted with JSI, and one unique and exciting feature that we have as part of this program is our Patient Experience Committee, which is comprised of both patients and doulas to inform our evaluation approach. We're also collecting quantitative data including enrollment numbers, doula visits, demographic data, which includes race and ethnicity, and birth outcomes and complications. And this summer, we're looking forward to also bringing a summer fellow on to continue to explore additional opportunities in the maternal health space. Next slide. Next slide, please.
Okay, so I think Taylor, I'm taking that as a handoff to me. Before I start, let me just pause and check in with Commissioner Blakeney and David Seltz to decide whether we want to take an additional 5 minutes and wrap this up, or if we should end on the high note of 37 Beside babies and stop now. What would you prefer?
I'm happy if the team is able to give us another 5 or 10 minutes to get this wrapped up. And this is such a great presentation, and the impact of this work is profound, and I don't want to shortcut it. So please, Haley.
All right. Well, thank you very much. And I will try to be brief. And as I said, what's the thing about children and animals? I'm not sure I can measure up to 37 Beside babies. But be that as it may, let me take a step back here. As you just heard, Mass Up, C%, and Beside are all quite different programs in terms not only of their focus and goals, but also where they are in their life cycle. That said, we have seen some significant commonalities. As I mentioned earlier, all three launched during the COVID-19 pandemic. In fact, we undertook review and selection for 22 Mass Up proposals in March 2020, back when Zoom was a fun new novelty. I would say in general, pandemic challenges did not significantly and have not significantly influenced interest in our investment programs. In fact, some applicants cited the pandemic as making the need for these programs even more pressing. That said, the pandemic and its ripple effects have had implications for how all of these programs have been executed. I would say by and large, programs made adaptations to their programs to adapt to pandemic-driven needs, while also, working really hard to stay true to their core vision and program design. Catherine mentioned an example of that in her presentation, and just to reiterate the point, for example, at Mass Up Springfield, in lieu of hosting their in-person markets, which obviously became impossible with COVID, they established weekly distribution of CSA boxes supplied by BIPOC refugee farmers. So that obviously responded to an immediate need, but at the same time, as Catherine described earlier, they were able to continue in parallel their work around HIP. But the workforce challenges we've noted so many times in so many different presentations have affected and continue to affect these programs. Some things we would have expected. For example, we were not surprised to see that awardees struggled with losing some key staff, because we've been seeing that in many different places in the healthcare delivery system. In our case, it was more likely to be loss of administrative and care management staff as opposed to clinical folks. In any case, that really did stretch the capacity of our awardees to deliver against their program goals sometimes. There were other things that were a bit more of a surprise, maybe not so much in retrospect, but in the moment. For example, in addition to affecting program operations, staffing shortages slowed down some key administrative processes that had implications for how we manage the programs. For example, in some cases, gaps in staffing on or around IRBs meant that getting necessary approvals for components of our evaluation work were notably slower than we would have anticipated. Understaffed human resources functions and the backlog of unfilled positions we've been hearing about meant that posting for and hiring programmatic roles could be slower than we expected. And we also learned that workforce issues were not limited to healthcare organizations. Many of our awardees reported seeing vacancies and lower staffing levels at community-based organizations as well. But I think, overall, the programs demonstrated considerable resilience. And in most cases, the pace of their enrollment and their activities picked up very quickly after some slow starts. And as Taylor and Catherine both mentioned, our ability to use no-cost extensions as a way to offer some more time under these circumstances has really been a terrific opportunity for us. Next slide, please. I also don't want to underplay the theme of health equity that has really permeated all these programs. In addition to launching during COVID, all of these programs launched near or around the social justice protests in 2020. And to varying degrees, it affected both the work and, as important, the individuals doing the work under these programs. One really interesting thing we heard recently from one of our Mass Up partnerships was that in light of the murder of George Floyd and the protests that followed, they really just couldn't stick to the agenda and follow the implementation plan they proposed. as a partnership of people from the community working together. They had to at least try to grapple with what they were seeing and the feelings it was eliciting among members of the partnership before they could make any progress in anything else. And I think they really, in retrospect, communicated that they appreciated our flexibility in letting them do that, and that it ultimately empowered them to do the work better as they move forward. But even if everyone wasn't experiencing exactly that level of personal reckoning, many were motivated to make health equity more central to their programs, even if they were not necessarily required to do so. And I think all of that really challenged us as a team to think about how we could do a better job supporting the awardees in that effort and how we might develop a more robust approach in the future. Next slide. So we're going to continue to do pattern recognition through the life cycle of these programs and obviously through our evaluation process. You know, I don't want to belabor this, especially given time, but just to kind of summarize some of the things that we want to take a look at. You know, we'd like to look at the duration of programs and the realistic pace of spending and just see what we've learned about how the size and scope of these programs affects those things. Another thing we want to take a look at is reasonable expectations. As I think we mentioned earlier, I may have mentioned earlier, these are somewhat smaller grants than some of our early ones, not universally, but in some cases, and we want to make sure that our expectations align with that. We're going to continue to refine our evaluation planning, particularly around patient experience, and make sure that we are, engaging with our awardees early to increase the chances that we get the best quality data to understand the impact of our programs. We'd like to continue our efforts to take a holistic view of value. Obviously, impact on cost is always of interest to us. Also looking at to whom that financial value is accruing and when. And then finally, looking at other outcomes that matter: quality, patient satisfaction, social benefit, equity, and the like, so that we really have a comprehensive view. And then finally, we're always interested in sustainability. We talked a little bit in the prior bullet about financial sustainability, but we're interested in continuing to learn from our awardees and further research about the opportunity to understand the impact of culture and behavior change, and also to work with our awardees to ensure that the work they are doing with us positions them well to secure additional longer-term funding. And then finally, there's always the topic of, what's next and potential new investment opportunities. That is a topic for a different day, but we're obviously very interested in commissioner feedback on that as well. So with that, let me end and open the floor to any questions.
Pardon me, Kelly. Are there any questions? Kelly, let me then thank you and your team, Catherine and Taylor, for the great work that you've been doing since the approval of these programs and the implementation of them. I find this work extraordinarily exciting. The old community organizer in me just responds to this and gets very, very excited. So thank you for the work, and I look forward to working with you to think about what the next stage of this work should be. As each time we go through a cycle, we learn more and start to understand how to structure and how to fund programs to get the optimal outcomes for the community, as well as for the data that we need. And I loved how you finished with a comment about positioning these organizations to be well prepared for funding and other support mechanisms to continue the work that has worked well. I just congratulate you for that. And I'm very excited about the outcome for these 3 programs, but also the planning to go forward for the next round. So with that, I think what we want to do is take a look at the calendar. And there it is. David, I see, I just want to give you the opportunity if there's any last words of wisdom or thoughts that you'd like to share before we conclude.
Commissioner, you summed it up very well, and at the risk of repeating some of the things you said, I just want to give so much praise and credit to this investment team, this evaluation team, this learning and dissemination team that supports this incredible work. It cannot be overstated how much positive and unsolicited positive feedback we receive from these awardees about the opportunity to do this incredible work and to be supported by government in these activities, and the incredible positive impact it has on residents of the Commonwealth. And so we have a lot on our plate in terms of closing out these programs, evaluating them, getting as much learnings out of them. But as you said, we're also starting to pivot towards the future.
Mhm.
And where do we want to go next with another round of funding opportunities? And so I see that being a big part of our conversation this calendar year.
Mhm.
And thank you. And we can close out.
Okay, everybody, thank you all for sticking with us through a 3 and a quarter hour marathon session. And